A very good morning, everyone. Welcome to AIO's Guru Sangam, the 2025-2026 edition, where we educate, elevate, and excel. And this is the general session, session 24, and happens to be the last session of the entire Guru Sangam series. And I thank the AIO's dignitaries for the lovely arrangement that has been made for the postgraduates. Dr. Partha Biswas, sir, the president of AIOS, Dr. Santosh Ranawat, sir, Honorary General Secretary of AIOS, Dr. Manoj Chandra sir, Honorary Treasurer of AIOS. I also thank our speaker, the line of speakers for today. Dr. Sanjay Daulat Thakur, sir, from College of Medicine and Sagor Datta Hospital, Kolkata. Dr. Banakshi Dhar, ma'am, from Amrita School of Medicine, Faridabad. Dr. Indu Pandey, ma'am, from Jagivaram Hospital, Mumbai. And Dr. Chinmay J, ma'am, from Bangalore Medical College, Bangalore. Thank you so much for joining us. And our expert panel consists of Dr. C. Bala Subramanian, sir, from Achata Eye Care, Erode, and Dr. Mohita Sharma, ma'am, from Birupati Eye Center,
Good
Noida.
morning,
Dr.
everyone.
Piyush Bansal, sir, from Bansal Vision Institute, Pune. Dr. Ruchi Goyal, ma'am, from I7 Eye Hospital, New Delhi. And Dr. Tulika Chauhan, ma'am, from Center for Sight, New Delhi. Our flow of the webinar consists of the topics including clinical evaluation of optic disc in glaucoma, OCT in glaucoma, Meibomian gland dysfunction, diagnosis and treatment, and ending with the most important for all the postgraduates, art and science of suturing. Thank you so much for the flow. And I thank my moderator, co-moderator, Dr. Kanika Bharadwaj from Center for Sight, New Delhi, for joining us, and myself, Dr. Rolika Bansal from Mahatma Gandhi Medical College, Jaipur. I request our first speaker, Dr. Dhar sir, to please, Dr. Sanjay Daulat Thakur sir, to please share his presentation. Over to you, sir. And the topic for sir is clinical evaluation of optic disc in glaucoma.
So you can select the PPT, please.
Is my slide visible? Hello, is my slide visible?
No, sir, you'll have to click on the PPT, please.
I've.
So you have to, yes,
Yeah,
sir.
now it is.
Yes.
Is it visible?
Now,
Yes, sir.
yes.
Am I audible?
Yes, sir.
Good morning, everyone. First of all, I would like to thank the AIOS team for giving me this opportunity, and my wishes to all the panelists. So I'll be speaking on clinical evaluation of optic disc in glaucoma. The optic nerve head is the region where the ganglion cell axons leave the eyeball. Glaucoma has been defined as an optic neuropathy. So the characteristics of the disc are central to the diagnosis of glaucoma. Hence, the evaluation of the optic nerve head is critically important in not only diagnosing glaucoma but also staging glaucoma, whether it is mild, moderate, or advanced, and also to monitor the progression as the disease progresses or as the patient comes for follow-up. All the technological advances have been made in imaging and quantifying the disc. Clinical examination is still indispensable. Traditionally, we used to examine the optic nerve head with direct ophthalmoscope and used to use fundus camera for documentation. But now, since the emphasis has shifted to stereoscopic evaluation of the optic nerve head, we nowadays do slit lamp biomicroscopy with different types of non-contact lenses like 60D, 78D, or 90D. The important point to remember over here is that though 90D gives a wide field of view and is widely used by retina surgeons, but for glaucoma it becomes a disadvantage because the image is minified and we may miss some signs of glaucoma because of the minification. So in glaucoma patients, we usually use 60D or 78D for slit lamp biomicroscopy. Now, there are so many signs of glaucoma that you may miss some signs during your exam, like RNFL defect, VCDR, NRR, so many signs. So, there has to be a systematic way of evaluation of the optic disc. Robert Winrob et al. Described 5 steps of disc evaluation in patients with glaucoma, and it is popularly known as 5 R's. So these 5 R's are evaluation of the optic disc size, the rim evaluation, the disc hemorrhage, the peripapillary atrophy, and the retinal nerve fiber layer defect. First of all, we estimate the disc size. The disc size does not differ between glaucomatous or the non-glaucomatous eyes. In fact, it depends on the race. The whites have the smallest disc size and the blacks have the largest disc size. We, the Asians, have a intermediate or medium-sized optic disc. So, why is it important to estimate the disc size? Because large disc, we overestimate glaucoma. We have to remember that there are a constant number of nerve fibers leaving the eyeball. It's approximately 1.2 million nerve fibers which leave the eyeball. They are the axons of the retinal ganglion cells. Now, if the disc is large, so there's a large area. So the number of axons are same. So there is a large cup. Now, when we see a large cup, we tend to overestimate glaucoma. So we have to be very careful before we label a patient as glaucoma. So on the left side is a large disc with a physiological cup and normal rim. And on the right side is a large disc with a inferior loss of rim or notching, which has been shown as a white arrow. Vice versa happens in a small disc. We underestimate glaucoma because the cup size is smaller. Because the number of axons are same, the cup becomes smaller because the disc size is small. So we underestimate glaucoma in a small disc. But we have to be careful and we should look for signs of glaucoma in a small disc so that we don't miss them. On this left side is a small disc with a normal rim, and on the right side is a small disc with again notching and a RNFL defect shown by white arrows. So we should be very careful in small disc of missing glaucoma and in a large disc of labeling glaucoma. In a busy OPD, how do we estimate whether the size of the disc is small or normal or large? So a 5-degree aperture of Welschelen ophthalmoscope will produce a spot of light whose diameter is 1.5 millimeter. And normally the vertical diameter is 1.8 millimeters and horizontal diameter is 1.7 millimeters. So we can grossly decide whether the disc is normal or small or large. But if we want to accurately measure the disc size, then we have to do slit lamp biomicroscopy, adjust the height of the slit, and then see the reading on the slit lamp, and then we have to multiply it with the correction factor depending on the lens used. If we use 60-degree, then we don't have to use any correction factor to get the disc size. But if we are using 90D, then we have to multiply by 1.3. First, we adjust the height of the slit lamp to measure the disc diameter, either vertical or horizontal, then see the reading on the slit lamp, and then, if necessary, multiply. Like if we are using 90, then we have to multiply by 1.3 to get the accurate disc size. In glaucoma, there is a absolute increase in the cup size and hence the cup disc ratio. Usually in glaucoma, the superior and the inferior poles are first to be affected. So the increase is more vertically than horizontally. So vertical cup disc ratio gains important in glaucoma patients. And it is a simple, relatively robust sign of glaucoma. And we have to remember that any cupping up to 0.4 is physiological. Any cupping of 0.5 or more is suspicious of glaucoma. These slides will help you guide how a 0.5 VCDR looks like or how a 0.7 VCDR looks like. One thing important you all should remember is that the point of deviation of vessels on the surface of the disc is used to determine the cup margin and not the pallor of the disc. It's the deviation of the vessels on the surface of the disc which will guide you to determine the cupping size. Usually, the right eye and the left eye of a patient resemble each other or are symmetrical. Any asymmetry in the vertical cup disc ratio of zero point 0.2 or more is suggestive of glaucoma. So, in the past, we were focusing more on the cup, and since it was vertically enlarged, so VCDR ratio was very popular way of diagnosing glaucoma. But as of now, the emphasis has shifted to neuroretinal rim, because you have to remember that the primary pathology is the loss of the neural rim tissue because of the apoptosis of the ganglion cells in glaucoma, and the enlargement of the cup is secondary. So now we have shifted to the rim. Instead of more focus on the cupping, we have now shifted to focus on the rim. Now, how do we know that the rim is normal or abnormal? So there is a very simple rule called isn't rule. It says the inferior rim is the thickest, followed by superior, followed by nasal, and followed by temporal. So in glaucoma, the inferior rim may be thinned. So this rule is altered. Now, if the rule is altered, then this is suggestive of glaucoma. So isn't rule nowadays is very important to determine the healthy rim or not is present. Now neuroretinal rim may be uniformly decreased as shown in these photographs, or it may be localized thinning of the neuroretinal rim in any particular sector. Usually the inferior or the superior poles are affected by notching. The thinning is commonly seen in the inferior sector or the superior sector. So here are a couple of photographs showing the inferior notching, and the notching is clearly visible by the bend of the vessel at the surface of the cup. The next important finding we should always carefully look for is the disc hemorrhage. It is a strong indicator of progression of glaucoma, and it is more commonly seen in normotensive glaucoma. If we are not careful, this disc hemorrhage might be small and we may miss it. These disc hemorrhages are transient. They disappear after some time. They are usually seen in the region of notching. Sometimes they precede notching also. And after disc hemorrhage, you may see a wedge RNFL defect in that area also. The next important R among the 5 R's is the peripapillary atrophy. Now, in the peripapillary zone, there are two zones, the outer alpha zone as marked by black arrows and inner beta zone as marked by white arrows. In peripapillary choroidal atrophy, there is a atrophy of the RP and the choriocapillaries, and we can see the sclera and the choroidal vessels very clearly. This usually happens in glaucoma in the beta zone. If there is a peripapillary atrophy of 360 degrees, then that is known as haloglaucomatosis. This atrophy does not happen in non-glaucomatous conditions. So the presence of peripapillary atrophy in the beta zone helps us to distinguish it from non-glaucomatous conditions. That is why it is important. Then we have to see the RNFL. RNFL now is a very important parameter in the diagnosis of glaucoma. It is 85% specific for glaucoma. So it is very important. We should carefully evaluate the RNFL. RNFL is seen as bright, fine striations fanning out from the optic disc in the superior temporal arcade and in the inferior temporal arcade in the healthy eyes. Now, this is very clearly seen or better visualized with the red free light, because the green light is absorbed by the RP and the choriocapillaries, giving us a dark background. And then the bright light from the RNFL is reflected back. So we can easily see the RNFL more clearly in this dark background. So if we can see the RNFL brightness and striations clearly, then we can easily identify the defects also. These defects may be slit-like as shown in this photograph, or they may be wedge-shaped as shown in these couple of photographs. On the left is the normal fundus photograph showing the wedge defect, and on the right is a red-free photograph showing the wedge RNFL defect in the superotemporal nerve fiber bundle. These defects appear as dark areas in the areas where it's supposed to be bright. In the RNFL, healthy RNFL, they are supposed to be bright striations, fine striations. Now, because of the defect, there are dark areas in this segment. And when there's a generalized RNFL defect, the fundus looks like this. All the vessels are margins are sharply demarcated and all the striations are absent. Then we come to the vascular signs. And one of the important vascular signs is the bayoneting of vessels. Bayonets are usually seen in the guns. This has been named after the bayonets of the guns. Now, why it has been named so? Because there is a double bending of the vessels like of the bayonet. The vessels bend twice, once at the base of the cup and second time at the surface of the cup. The vessels travel along the base of the cup and they climb the overhanging edge of the neuroretinal rim, and they make a sharp bend when they reach the surface of the cup. So you have two angulations. So that is why it has been named as bayoneting. And this is the important sign in glaucoma. Next is the bearing of the vessels. Normally, the circumlinear vessels follow the cup margin as shown on the left side of the photograph. But when the cup enlarges, the circumlinear vessel seem to hang in the mid-air. Some seems to be suspended in the mid-air, and there is an area of pallor between the circumlinear vessel and the cup margin, and this is known as bearing of vessels, and this area of pallor is shown in the right photograph by the red arrow. Then we come to the next sign, laminar dot sign. Lamina cribrosa is the part of a sclera with a mesh-like structure. The axons of the ganglion cells leave through these pores in the lamina cribrosa. Now, in glaucoma, when there's loss of ganglion cells and the nerve fibers, these pores become visible, and this is known as laminar dot sign. Because of the raised intraocular pressure, the lamina cribrosa is bulged backwards, and these pores become deformed. Then there is another sign called nasalization of vessels. This is not so specific for glaucoma, but what it happens in this case is that there is loss of neural tissue in the superior rim, in the inferior rim, and the temporal rim. Now, the only structural support left is nasally. Usually, the vessels enter or leave the eye nasally. So, when there is a large cup in advanced glaucoma, then vessels seem to shift nasally, and this is known as nasalization of vessels. A very important sign in glaucoma is the acquired pitting of the optic nerve. What is it? It is deep localized notching where the lamina cribrosa is visible at the disc margin, as shown by the white arrow in this photograph. This is one of the definite signs of glaucoma. So we should carefully look for it, so that we don't miss. But it is not very commonly seen. How do we differentiate it from the glaucomatous cupping? On the left side, you can see the glaucomatous cupping is uniformly deep, but in the acquired pitting, it is a localized peripheral area of pitting, as shown in the right photograph with blue arrows. So we have discussed so many signs. Now, some signs are more important than the others. So, but we have to remember that it's a combination of signs which help us in the diagnosis of glaucoma. So, like notching, asymmetry of eyes, vertical extension of the cup, they are highly suggestive. Disc hemorrhage, bayoneting sign, they are highly suggestive of glaucoma. And as I said, acquired pitting of the optic nerve is one of the definite signs of glaucoma. Then the other definite sign of glaucoma is documented diffuse thinning of the neuroretinal rim when the patient comes to you for follow-up serially over a period of time, or the reverse way, documented concentric enlargement of the cup. These are the definite signs of glaucoma. Other signs are mildly suggestive or moderately suggestive. But remember, it is a combination of the signs which help us in the diagnosis of glaucoma. Then the next important thing we should remember is the documentation of the disc findings. We can use the fundus camera and keep the document for the records. Stereo photography of the disc is still the gold standard, but it is difficult and not practical in all centers. The easier way out is we should do a drawing of the disc findings. We all clinicians should make a disc drawing in our notes, and not only at the baseline but on all the follow-ups, so that we can ourselves see the changes in the disc findings over a period of time when the patient comes to us for regular follow-ups. And that will help us in monitoring the progression and managing the patients accordingly. So disc documentation, especially disc drawings, are very important part in managing the glaucoma patients. Now to classify the disc damage, Armeli described a method in 1960s. It was based on the vertical cup disc ratio, graded from zero point 0.1 to zero point 0.8. This user-friendly system was widely accepted and soon became the standard across the world. It's very easy to see the cup and then accordingly determine the vertical cup disc ratio and then classify glaucoma based on the vertical cup disc ratio, whether it is early or moderate or advanced. But then the emphasis, as I said, shifted from the cup to the rim. So Jonas in 1988 described a classification system based primarily on the nature of the rim rather than the cup. This was modified several times, and the latest version of Spade's disk damage likelihoods scale, described in 2003, has 10 stages. It is based on the rim disk ratio. It estimates the width of the neuroretinal rim, and the classification is based on the narrowest width of the rim in any position. And if the rim is absent, then the circumferential extent of the rim loss helps us in staging the disc damage. So as you can see, DDLS stage 1 to 4 are at risk, and 5 to 7 are glaucoma damage, and 8 to 10 are basically in the glaucoma disability group. So we should always do the staging of the disc damage because our management depends accordingly. As you know, if the glaucoma is early, then the target IOP will be lesser, and we can keep it in the high teens. And if the if the disc damage is advanced, then we have to keep the target IOP in the low teens. So staging the disc damage is important for management of glaucoma. So that is a large number of signs we have discussed, and the combination will help us in the diagnosis of glaucoma. I would take this opportunities to thank all my gurus who taught me ophthalmology and all my students who motivated me to teach. And I would like to thank all my institutes from where I learned ophthalmology. Thank you. Thank you for your opportunity given to me by the All India Society.
Thank you so much, sir. That was such an illustrative and elaborate evaluation protocol for the disc management. I'm sure the students are going to benefit much out of it. May I request our panelists, Dr. Piyush sir, Dr. Mohita ma'am, if you would like to comment on the topic that has been discussed, anything that you would like to add?
Sure, Kanika. Very good morning to everyone. I'm Dr. Piyush Bansal, Chairman of the Scientific Committee of Maharashtra. And although I'm a retina surgeon, but by training at LVP, I spiked a special interest in glaucoma. So first of all, thank you and congratulations to Sanjay Thakur sir. I think he's covered it comprehensively. Just two or three points that perhaps I would like to add. Of course, I'm amenable to corrections. Is that even though we learned the isn't rule as fellows and as residents, but what I've seen in practice is that it's not really followed all the time. 30 to 40% of the times it is not followed, and these discs might be physiological, especially in myopics. So what is also important is to look at focal thinning rather than just not looking at focal thinning or notching, especially in the inferotemporal or the supratemporal area, rather than a diffuse kind of a thinning. Having said that, another thing that I would like to point out is in these large discs, sometimes you might think that it's physiological cupping, but what you look for is an asymmetry between both the discs. If you find a significant asymmetry to the tune of say more than 0.1, then you might consider it to be glaucomatous, and it's especially useful to pursue those ones. And the third one, which is also very important for practice, is that many a times we don't want to miss pre-perimetric glaucoma. We should not be over enthusiastic in diagnosing them. Of course, we want a correlation with the perimetry. But if you see a specific notching, if you see disc hemorrhages like Dr. Thakur sir showed, then in those situations you can consider treating even if there is no perimetric damage, if you see a valid progression over a period of time. So just my 3 cents.
Thank you, sir. That's appropriate what you have already informed. Theoretical and practical knowledge both must coincide. May I now request Dr. Mohita ma'am for her comments?
Yeah, good morning, everybody. Very well covered by Dr. Sanjay Thakur. Everything was what is important has already been covered by him. I only want to say one very important thing, that whenever a patient, this for all students, whenever a patient comes for any problem related to eye, it is our responsibility to check the fundus and the disc once. Many times I've seen that that some people will only check the anterior segment if they came for a small problem like anything related to allergy, conjunctivitis. Not conjunctivitis, we cannot go very close to the patient, but any other problem, then checking the fundus is a must, because there are a lot of cases of glaucoma who are still undiagnosed. That is one. And secondly, we have to depend a lot on our clinical acumen. So many signs have been told today, whether it is laminar dot sign, whether it is cup asymmetry, whether it is bayoneting, etc. Now, everything is actually visible when we start looking for it. And again, seen that many a times clinicians are becoming dependent on investigations like OCT and trying to assess the cup eye OCT. So your clinical acumen, where you see the fundus yourself and you look for all these signs, is what is going to be very helpful in diagnosing glaucoma, as well as if there is a glaucoma suspect, then checking on the progression. And already, as already mentioned, it's very important to take a disc photograph, and along with the disc photograph also note down all the findings, because the photograph has to be very clear for all the findings to be visible, and if they are not so visible, then whatever you have seen with your eyes, that needs to be noted down for a for good assessment of the progression. So that's all I wanted to say.
Thank you, ma'am. Very nicely summarized. May I now request Dr. Balasubramaniam sir to give his 2 cents on the topic?
Yeah, excellent presentation again by Dr. Thakur sir. Just few points to add. As Dr. Thakur sir has said, from the postgraduate point of view, the common mistake is to measure the size of the cup corresponding to the pallor. So pallor and cup are two different things, especially in early glaucoma. The cup might be larger than the pallor, one. And similarly in advanced glaucoma, you'll have neuroretinal rim thinning and never pallor. This is important to differentiate a compressive optic neuropathy, where you'll still have cupping of the disc. Along with that, you'll have NRR pallor, but you'll never get neuroretinal rim pallor in glaucoma. And from the exam point of view, from peripapillary atrophy, as Thakur sir had said, about alpha zone, beta zone, usually it'll get confused, which is closer to the disc. A small trick is A for away from the disc, B for bordering the disc. So alpha is away from the disc, and beta zone is bordering this. This is from the PG's exam point of view. Once again, he has covered it extensively. Thank you.
Thank you so much, sir. Do any of our panelists want to add to this, or should we move on to the next topic?
I think Dr. Ruchi wants to add. Ma'am, you.
Yeah, Dr. Ruchi Desai, yeah, fine.
Good
So,
morning.
yeah, it's a very nice presentation. And I think one a most important part of our, armatorium is the clinical examination, which is sadly being missed nowadays. And we are mostly relying on OCTs, which are not too great in actually managing the progression and everything. It's the clinical sense which needs to be very good. Um, I just wanted to ask one question. Like, a lot of patients are being referred for glaucoma screening prior to refractive surgery, because that seems to be the most in thing nowadays. And any points, Dr. Thakur, would you like to add just to pick up early glaucoma in these young children who are undergoing refractive surgery?
You can do the clinical examination as I have described, and if you find it normal, another thing you can add is nowadays OCT is the only option available to diagnose pre-perimetric glaucoma. So we can do a OCT analysis of RNFL and the ganglions and analysis, and keep a baseline. If we can find any findings suggestive of glaucoma, then we can highlight that. Otherwise, we can't do anything to diagnose from the clinical point of view unless there are specific signs.
Actually, unfortunately, most of these are high myopes with large cups. And if you look at their OCT also, they would have a lot of thinning. So it's actually a gray zone still. You can never be really sure whether these patients are going to land up into glaucoma post refractive surgery. So, yeah.
We can just
I think,
follow up and then treat accordingly.
yeah, so maybe the best would be, I think some of these, we need to stall them for a year or so, and just keep a watch, and then maybe we can, give them a clear-cut check to undergo refractive surgery.
Especially in high myopes, it's
Yeah,
true.
high myopes, yeah.
Meenakshi ma'am, you would like to say something?
Yeah, so Dr. Ruchi, you brought out a good point and about myopes. But some things I can, what is important is that we keep a baseline of all these things. If there is a field defect, as you said, we will follow it up and see if it is not progressing. We can take that. Now, there are certain findings that in myopes, the nasal thinning seems to occur, and the nerve fibers tend to go towards temporally. So OCT also may not pick up, especially if they are high myopes. So one has to have the clinical suspicion and never miss out the angle. One should not assume that the angle is open because it's a myope. Many a times we have seen patients coming who have narrow angles, so we can give them the benefit of a PI prior to the doing the procedure.
I'm not so sure about that regarding, even though I am not a refractive surgeon and don't stand to gain anything out of it by stalling their surgery. But not just these youngsters, but even this suspects post 40 or 45, their RNFNL analysis does show suspicion. Clinically also they seem to be suspects, but perimetry of course does not show any damage. And when you follow these patients up also, whether a year or 2 years, because I have so many of them over a period of 5 years, they've not progressed. So I'm not very convinced whether we should stall these young individuals who have the opportunity to get rid of their glasses just on the basis of a dissuspicion.
We are not stalling. We are just telling them this may be a thing. Let's watch you over for some time. If you are willing to wait and do it, it's a more judicious decision which will be taken.
And how long would you wait, ma'am?
Say 6 months. We would have seen the patient a couple of times. We would have taken the eye pressures at different points of time. And we may get, because sometimes patients come out with a history much later, or the use of some things. So some medication. So all these things, once we have ruled out that it is a physiological, not a pathological changes that we are seeing, then one can go ahead.
Okay.
Sure, ma'am. Being a refractive surgeon myself, I would also like to add to this, ma'am, that nowadays, because most people, we are in the myopia pandemic, as we all know, most people are now turning up for refractive surgeries, young children who have to join multiple things. So I think the legal implications are also there when we are actually documenting a baseline investigation for glaucoma in such people, because obviously in future their corneal thickness would be less and their IOP measurements would always be false. So, of course, there is a legal implication. Like ma'am said, my preference is if there is no genetic history in the family or in the near relatives or anyone, then I do not generally stall the surgery. But yes, I do keep a baseline evaluation of the optic nerves ready so that in future, if there is even a slightest chance, we can reassess and we can compare it with those previous investigations. Having said all that, now let us proceed to the next topic. May I invite Dr. Meenakshi ma'am to share her screen and give us her insights into OCT in glaucoma.
Can you see my screen?
Yes, ma'am. Please go on to the full presentation mode, ma'am.
Yeah.
Ma'am, can you just make it in full screen slideshow mode? You can press the play button on top.
I don't know where it disappeared. I was very much on it.
I think, ma'am, you have minimized the screen. Kindly maximize the screen and then put your cursor on the play button.
Yeah, I'll.
Ma'am, you can reshare and just press the play button on top.
Yeah, I'm just wondering why it was everything was happening fine. Okay.
We can see your screen, ma'am.
Now, if you will click on the play button above the OCT.
Is that fine?
Yes, ma'am.
Perfect.
Yeah, thank you.
Over to you.
A very good morning to all, and thank you to the co-moderators and the panelists, and a big thank you to Dr. Santosh and the AIOS team. We are talking of, we've had a wonderful session taken by, can you just, I don't want my own face to come on the thing because it is covering part of my thing. How do I take it out?
I think, ma'am, you will need to switch between the presenter view.
Because it's covering part of my screen. I don't know how to.
And there might be a column which says view on the right-hand corner on the top. And it has multiple options, and you can just put standard over there. And it also says hide self view. It's a drop-down menu on the right upper hand corner next to the minimize button.
Sorry, where do I go?
On the right upper hand corner next to the minimize button, you will find a title that says view. When you click that, it's a drop-down menu. And
yeah, I've gone to, it says more.
Okay. So Sunilji, perhaps you can help her, because from what I see is when you click the view button, it says standard on the top, and then there's a long list of subheadings, and one of them is hide self view. If you found that, because we can see your slides.
Yeah, I know you can, but I also need to read my slides.
Okay, Sunilji, can you help her? Or would you mind ending your presentation, screen show, and then resharing it again?
Yeah, I'll do that. So in the view, I'll just minimize my. Okay, fine. Is it sharing now?
Yes, it's sharing. We just need to go for it to go full screen.
Is it fine?
It's perfect now.
That doesn't seem to go somehow. My thing is gone, but the whole column is there.
The column of the speakers, you mean?
Yeah.
So for
And
that,
you can long press and move on this, or you can continue with.
are you able to see the slides now?
I am able to see my slides, but they're getting.
Do you see the
never
view?
had this problem before.
No problem, ma'am. Do you we'll solve it. Do you see the view button on the top?
I'm on the floating deck. Just long press and don't release, and you can move it left and right wherever you want.
Okay. Are my slides still showing?
Yes, but you need to put it in slideshow mode now.
1 second.
Can you try stopping and resharing again, if possible now?
So I can see everybody's faces now.
You need to reshare, ma'am. Perfect, ma'am. And you can just put the play button now.
Is it coming okay now?
Perfect, ma'am. You can continue.
Thank you so
please.
much. Sorry for this. Now, we have had a wonderful presentation on the clinical picture of optic nerve head. And in the last few decades, another thing we can now actually map the structurally the optic nerve head and with the help of the optical coherence tomography. And it is useful in pre-perimetric glaucoma, perimetric glaucoma, to find out if there is progression. The anterior segment imaging helps us especially in patients with angle closure glaucoma. It was the time domain stratoscopy which was introduced in 2002 after the initial one which came in 1991. The advantages of optical coherence tomography is that it is a non-contact, non-invasive imaging technique which has a very high resolution and gives cross-sectional retinal images using the low coherent light. The OCT quantifies the retinal nerve fiber layer thinning, which is the site of destruction in glaucoma. And it also gives us the ganglion cell complex and the optic disc parameters. It can also help us in monitoring progression, and it is believed that up to the moderate glaucoma, it has got a better chances of detecting changes than the visual fields. But as we have already emphasized, OCT cannot be diagnosed, nor can it be treated, nor can it be progression can be checked just based on its report. The pivots of clinical examination, gonioscopy, optic nerve examination, visual fields, all have to be correlated before one gets one comes to a conclusion about the patient. The OCT reveals layers of the retina by looking at the interface patterns of the reflected laser light. And the automated software segmentation algorithms are able to outline the retinal nerve fiber layer with precision. There are many makers currently which are popular, and each surgeon has their own favorite. I am not that there is an advantage of one over the other, but since I have used the Cirrus, I will be talking more about it. It has the advantage of, now all these have the advantage of higher image axial resolution, which is taken in a short time. One should remember that readings from one machine cannot be interchanged with that from another. So if you are following with your machine, and a patient comes with another, it's not just for you should repeat it on the machine that you would be following up the patient with. So there is a 3D mapping of the optic nerve head, which is done. There are more than 26,000 A scans taken per second. It has a resolution of around 5 microns. The RNFL on this on Cirrus is thinner than what it was in Stratus. So between the same company also, you can not use interchangeably from one model to another. We can also do the ganglion cell layer analysis. And the advantage is that it is very user-friendly and it automatically centers the scan on the optic disc. So it is less operator dependent and the scan-rescan variability is much less. We do luckily have a normative database, but if you actually see, the normative database was on a very small subset of people, which included healthy Caucasians, Asians, and Indians were only 1%. So we need to keep this in mind whenever we are looking at at what we are getting, and not just take it as something that as gold standard. The refractive error that these normative data had was between -12 to +8. So there goes that if it is a myope, it is not being covered through this, especially a high myope. And when we take the RNFL, so we take a 6 into 6 cube of A scan data centered of the optic nerve head, and take a 3.4 circle of the RNFL around the disc. So it's like opening a ribbon, and then when the ribbon is open, so each of these points is telling you the RNFL thickness at these points on the circumference on the circle of at 3.4 and this has a double hump pattern, which as Dr. Thakur had said, that the humps are the ones which correspond to the superior thickness and the inferior thickness, which is higher than the nerve fiber layer thickness in the temporal or the nasal quadrants. When we are looking at the printout, it can sometimes be, if we have the forum, the visual fields also can be on the same printout, so one can correlate between the structural and the functional aspect and be able to interpret the thing better. We should always read the printout methodically, not jump at a conclusion and not just chase the red or green disease. When we are looking at, just like when we do a methodical analysis of a visual field printout, we should do one of the OCT. The zone 1 corresponds to the patient data. The second is the signal strength, which should be at least 5 or more than 5, because less than that, it should be rejected and is not conveying the actual clinical picture. One should then see the zone 3, which is the thickness of the map. Zone 4 conveys the deviation map. Zone 5 gives us all the optic nerve head and RNFL parameters, the average RNFL thickness, how much symmetry is there between the two eyes, the rim area, which is very important, and also the cup disc ratio and the cup volume. We also the neuroretinal layer thickness graph is there, but the most important one that we look at is the RNFL thickness graph, which normally follows the Tisnett rule. That is, there is a hump at the superior and the inferior, and this gets altered in glaucoma. Like, for instance, in this patient, one can see that there is a borderline thinning. So what do these red, green, and yellow signify? If the green signifies there is a 95% of probability of it being normal. The yellow signifies that there is a 5% chance of it being within the normal, and the 1% corresponds to the red. That means it is more likely to be abnormal. The ganglion cell complex is the chosen place to see on the macula, because 50% of the ganglion cells are in the macula. When we take the GCC measurement, it includes the inner plexiform layer and the ganglion cell bodies, but it excludes the neurofibril layer. It is most representative in the infratemporal sector, and it correlates earliest with glaucoma. Nasal sectors are least representative of glaucoma change. The other sectors which could and parameters which could be helpful in glaucoma is the minimum and average GCL plus IPL, the thickness, the supratemporal sector, and the inferior sector. So when this is measured, there is a cube which is used, which is got a square grid of 6 to 6 mm with and a thickness of 2 mm, which is like an annulus around the fovea, with an inner vertical diameter of 1 millimeter and an outer one of 4. This is done to avoid the areas difficult to segment and measure accurately, those that lie within and outside this limit. So if you see, for example, this patient of ours, who is a 79-year-old lady, she had a mixed type of glaucoma. She was on PGA. She has a notch in the inferior at the inferior pole, which corresponds to a thinning of the RNFL in the inferior quadrant. In the other eye, she had a notching at the superior pole, which corresponds to a thinning of the superior quadrant. And this patient had an early perimetric PACG. Whenever we are looking at this, we should always find out if there are any fallacies which should prevent you from relying on that printout that you have got. So, for instance, in this patient, the age of the patient was erroneously entered as being the date of the examination. So one had it totally got lopsided, the printout. Also, we need to look at errors, like I had already said about the poor signal strength, which should not be less than 5. And the decreased signal strength is found in patients with cataract, media opacities, corneal edema, vitreous floaters, and dry eye. So whenever one practical thing to do is, if you're not getting a good scan, you can put a lubricant and do it after a couple of minutes. If it's because of the dry eye, you will get a good printout. Vitreous opacities can again hinder from a good scan being taken, both on the RNFL and the GCC. False positive red disease can also be seen in patients with high myopia, ARMD, and post-PRP. For instance, in the post-PRP patients, the calculation circle passes through an area of peripapillary atrophy, and as there is no RNFL, it naturally dips at that point. It is not that it has got a 0 RNFL thickness. Again, blinking artifacts, although the capture time is very short, but even then sometimes they can play a role, and these scans should not be considered. The segmentation is also important. Software tries to segment out the RNFL, but if the scan quality isn't good, the segmentation will be thrown off and lead to inaccurate values. The RNFL is supposed to be the area between the two red lines, which is seen, and anything that affects the scan quality can cause this type of a defect, which includes tilted discs, staphylomas, large peripapillary atrophies, the periretinal membranes, and PVD. So a clinical examination needs to be kept in mind when you are interpreting your scan. Again, if the scan is not properly aligned, as has been shown by the brown arrow, it is going superior. So it has led to a fallacious decrease in the nasal quadrant of the RNFL, and it is not that the patient is having a thinning of the RNFL there. This can be sometimes in high axial myopia or just the way the thing has been done. So this is one of our Caucasian patients who came, who was suspicious of had a suspicious disc, and we found this nasal thinning. So we were wondering what to do, and we told him that it seems physiological, and so he came later to us in 2017, and when we did it, it was all normal, and that's when we realized it is just because of the wrong alignment that it was picking up as an abnormal finding, and this was corroborated by a repeat finding in 2018. So as we should avoid red disease, so we should avoid green disease, because progression can happen in the green, and if because optic nerve head edema or macular edema may not be maybe covering up for the RNFL, which is actually getting thinned out. So the sector still remains within the normal range, so it shows as thinning and lack of thinning. So RNFL does not pick up focal disease. In contrast, when we do a GCC, it does pick up a focal disease, as seen in this patient, where there was a notching which has been picked up in the infratemporal sector. In myopia, it is always a dilemma, and both the structural and functional defects in myopia and glaucoma are similar. The myopes are at higher risk for glaucoma, and if the axial length is more than 25.5, they are at 16 times more risk of having glaucoma. So one should keep the tests, all the tests, a baseline, and then follow up from that if there are any changes occurring. The average RNFL is thinner in these patients, and nasal thinning is more there, and nerve fibers in these patients shift temporally. The peripapillary atrophy also complicates the readings of RNFL thickness that we are getting. In moderate to high myopia, OCT is not reliable to detect glaucoma, because also it is not included in the normative data. The NIDEC OCT, which has come now, has database for mild to moderate glaucoma. The longer the eye, the thinner the RNFL, we need to remember. So beware of false positives thanks to either a tilted disc or a myope. Look carefully at your disc picture clinically before you interpret any OCT. And if you get a scan of 2/10 and you get such a kind picture, this is one of our patients who had high myopia, glaucoma, and we tried to do the OCT, and this is what we could get because there was a posterior staphyloma. So please remember, OCT will not be helpful in such patients. This is another of our patients who with myopia and glaucoma with a good vision. He came to ask us, should I get operated for cataract because he had an early cataract? And we told him no, as of now, no, because when we looked at his disc, there is thinning, but that thinning is thanks to myopia. When one looks at his disc, there was a small coloboma near the disc, and that was contributing to his thinning of the RNFL. So beware of false positives, even when there is a bit retraction that could give you a lots of lumpy, bumpy pattern, and this is not glaucoma. So one should always correlate between the visual field and the OCT. OCT is useful in the early disease, and at this stage, the visual fields may not occur because visual fields are generally occur after 40% of the loss has occurred. So this is our pre-perimetric patient who had OCT findings which were in the on RNFL only. There was a borderline thinning in the left eye. But when one did the GCC, there was a infratemporal thinning in both the eyes, more so in the right eye. So this and the visual fields, of course, were normal. So these are early GCC changes. There was a study which had taken around 102 patients of primary open glaucoma, open angle glaucoma, and they found significant RNFL thinning in the superior, inferior, and nasal quadrants, as well as superior temporal and inferior sectors. The POAG and NTG patients had greater RNFL thinning in the inferiorly and infratemporally, and the pseudoexfoliative patients had it more thinning in the superior quadrant. The PDG glauc patients had greater RNFL thinning superiorly and supranasally. In patients of pseudoexfoliation glaucoma, there was more inter-eye RNFL asymmetry. And glaucoma is a slow disease, and changes occur only very slowly. Here we can see that from a borderline thinning in the left eye in 2013, the patient went on to having a marked proper thinning of the superior quadrant. So one needs to follow up these patients, and how often should one do it? Annually in every patient of glaucoma suspect and early disease, and biannually in moderate and severe disease. The progression speeds up on visual fields and seems to slow down on OCT. OCT uses a linear scale while the visual field maps used a logarithmic scale, and that's what brings out the difference. We should account for normal aging when we are talking of thinning, and loss of 0.33 microns occurs per year. And there are different, the decline in the superior RNFL is 1.35 microns per year, in the inferior 1.25 microns. So one has to keep that in mind when we are interpreting our results. So, but progression can be mapped in two ways, either event-based analysis, which is simply to compare one test to another. It has limitations of being susceptible to outliers and may identify false progression. What we should do is never compare it from the baseline test rather than from just the previous one. So you can, in spectral domain OCT, you have a 4 micron intervisit reproducibility. So that is why a difference of 8 or more Generally, they take it as 10, that if there is a 10 micron difference between the previous value and now in the same quadrant, it is taken as a significant decline. This is one of our patients in which you can see that there is a superior decline which was seen, and then so you call it a likelihood progression or a possible progression when we see this change. And this is the same patient. We can see the two eyes after they have been followed up for years as to how the changes have started occurring in the average RNFL, the inferior and in the superior quadrants. The second is the trend-based analysis. So here you're seeing the slope of change over time for each parameter. The rate of change is seen rather than the amount. Here it requires a lot of tests, and so we need to have a long follow-up before we can use this. So in this chart, one sees the thickness charts at the top. One sees the different parameters, whether it is the average RNFL, the superior or the inferior RNFL, or the average CD ratio, which has been mapped over time. And here again, we say whether it is a possible, with all these things are overlaid over the Tisnet pattern. And then we try to see if there has been a change and how, whether it is there or not. So whenever we are looking at a defect, we look at it whether there is appearance of a new defect, whether there is widening of the defect or deepening of the defect. Once RNFL reaches 50 microns or 40 microns, even if there is progression, it will not go down further, and that is a limitation. And so in advanced glaucoma, do not use RNFL to detect progression because of this floor effect. False sense of security may be there that there is no change happening. In these patients, visual fields, especially the tan-2, will be helpful. And the GCC may be helpful. OCT angio, all it tells you is that there are dropouts. In the pediatric age group, we do not have any normative data, and you can adjust to 18 years, but that may be fallacious. So it is better to compare their values from one test to another. When in very early childhood glaucoma, cupping may reverse, but the RNFL still stays decreased. RNFL thinning is not always glaucoma, and one should keep other causes of RNFL thinning in mind. ASOCT also is a type of OCT for the anterior chamber, anterior segment, and it can help you diagnose the shallow primary angle closures, give you the angle of opening, give you the lens vault, and also it is useful when refractive surgeons are planning their surgery. So it is an adjunct to gonioscopy, not a substitute for it. And we can redo it in the same axis. That is an advantage, and we can perform it in under dark conditions. And sometimes it may be the only thing that you can do because the patient doesn't cooperate for a gonioscopy. We can also do blebs analysis and anterior chamber implant analysis with the OCT. Like here, we can see the trap bleb of one of our patients, and you can see the subscleral bed of fluid as well. So one can map these trabecular blebs and whether they have and how is the echogenicity of the thing can tell us whether the bleb is functioning or not. So in nutshell, the OCT discriminates between eyes with early perimetric glaucoma and normalized, but less adequate in eyes with suspicious disc and normal visual fields. OHT eyes with the abnormal swap and normal achromatic visual fields had lower RNFL thickness in supratemporal and infratemporal sections of the peripapillary retina. In ocular hypertensives, 55% eyes that converted to glaucoma had structural changes in the optic nerve head. The OCT has the advantage of being reproducible, objective, and it gives cross-sectional images. It is independent for any arbitrarily defined reference, and they are in the future modalities could be ultra high speed swept source OCT, the ultra high resolution OCT, adaptive OCTs, and the other. So to conclude, we should use the same machine and consider the same parameters from one visit to another, do both an RNFL and GCC at the baseline, and check if normative data includes your patient profile or not. Spend time over your OCT printout, read it methodically, repeat it if necessary, look at the raw scans. Don't get blinded by red disease where patients get referred and sometimes even treated. Correlate it with your clinical parameters. Show the patient's results, because sometimes patients get more convinced when they see things in colors and all that, and they are able to identify and realize, yes, they do have a problem because they were essentially asymptomatic when they had visited you. Use different OCT parameters depending on the stage. Very early, use GCC. Early, use RNFL. And late, again, use GCC. Thank you for patient hearing.
Thank you so much, ma'am, for a detailed description of the OCT. And probably like all other investigations, OCT also has become a part of our daily clinics and assessment of the optic nerves. May I request the panelists to share their comments on this topic, and if they would like to add something from their side. Dr. Bala Subramaniam?
Yeah, I'm exhaustively covered. I don't think I have anything to add. Just about, in addition to RNFL, you also have data about NRR. So RNFL is more sensitive to pick up glaucoma, and NRR is more specific, related to sensitivity and specificity. But otherwise, I don't have anything else to add.
Dr. Thakur, sir, would you like to add something to ma'am's topic?
No, she has covered it very comprehensively. Only thing I would like to highlight is what Madam has already said, that because of the floor effect, it is not helpful in advanced glaucoma. So we should be careful. In advanced glaucoma, we should not use OCT for determining the progression, but we should use visual fields. And otherwise, OCT is helpful in early glaucomas, as she said.
Do we have any other panelists who would like to add? Dr. Piyush, sir, please go ahead, sir.
Thank you, Professor, for the masterclass. It was a good revision, fantastic revision for me. I don't think I'm an expert in this subspecialty. Just a few things that I would like to understand is that when you want to look at progression, whether it is in normative eyes or eyes with abnormal axial length or myopes, or say, for example, pediatric eyes or eyes with secondary glaucoma, when you're looking at the OCT and you want to look at progression, would you rate the optic cup, the RNFL as well as the GCC differently in all of these scenarios? Whether it is normal axial length, myopic, pediatric, or secondary glaucoma?
In what you are saying is, would your weightage to the three aspects be different at different ages? Yes, certainly. In a normal, a person of average age whose normative data is there, clinical sense and of course, has to be kept in mind. But what the RNFL is picking up here, we would respect. But in a patient who is high myope, what the RNFL is picking up is not what I will respect. I will respect the clinical scenario, the IOP, the patient's IOP, whether there are any clinical features of glaucoma on the optic disc, and do a good examination, and also keep serial examinations of the. So in our practice, we always take a fundus picture of the optic nerve head as part of the glaucoma workup, and try to so that, because that comparison, sometimes your image you can forget, and with the advent, unfortunately, of all our everything being computerized, it's very difficult to go back to our drawing. Those drawings were wonderful, but we can't go back to that. So, so as not to digress, in a myope, I would look at the clinical picture, the way the optic nerve head looks, the IOP is, the visual fields are, whether there are changes happening in that. give it more credence than what my OCT is
What
telling.
about the GCC as compared to RNFL? We know that the RNFL is going to be skewed.
GCC, if it is, I would respect GCC, but at the same time, I have to ensure that there is no other pathology happening in the macula which could complicate the picture that I. So every GCC thinning is not glaucoma thinning.
So the
It could be
macula is
because
fine. Now say the macula is fine. There's no ERM, there's no vitreomacular traction. But and we know that the RNFL might be skewed because of the longer axial length. So in that situation, you would give more importance to GCC as compared to
yes,
RNFL myopes?
yes, GCC, yes. And in children, again, we'll have to look at the clinical picture much more and be more cautious in them. So that because the child, not that the child will complain of anything, but this is the time that we need to be more careful that we don't miss out on early changes.
And anything in secondary glaucomas?
Secondary glaucomas? In secondary glaucomas, it's the clinical picture which is much, much more important than looking at these parameters. Because what is happening is at a greater magnitude, at a greater rate than what primary open angles do. Primary glaucomas in general, and more so open angle glaucomas. And they progress at a much slower speed, but the secondary glaucomas would progress. That's my view.
Okay. Another question, just for my clinical understanding, perhaps it might benefit others as well, is that, these normal tension glaucomas, somewhere around the range of, I wouldn't say glaucomas, but pressures of around 10, 12. And you have a suspicious disc, you get an OCT done, you get a perimetry done. Of course, the perimetry is absolutely normal. It might be pre-perimetric. And when do you actually start treatment? When you have consistent lower pressures. However, you see some amount of progression in the RNFL and some amount, very minimal, bare minimal amount of progression in the cup size also, in the NRL the parameters also. When do you actually start treatment, or do you just follow them up until you have perimetric damage?
So what you're saying is very right. Actually, like stalwarts like Dr. Ramanjeet and all say clearly that our but it's Caucasian level of IOP, which is 21. Our IOPs are actually lesser. So our glaucomas appear at a lesser IOPs than what they do in Caucasians. So we have to be more vigilant in ensuring that we are not missing out a disease. And if I feel that disc is looking glaucomatous, patient has no visual field changes, but has OCT changes, which are characteristic of glaucoma, and no other feature, and the angles are open, I will follow up the patient for say 6 months. And if I find a change happening in this, I will give the patient an informed, make him an informed partner. Do you want to put an eye drop and prevent your damage? Especially because some of them come from families who have had severe glaucomas. So I would be more, so it's the other risk factors which I'll take into consideration. Also, in some of these patients, we have to take whether are there patients who are like thin with low BPs and all that, they're more likely to actually worsen. Or at what time are you taking your antihypertensives? Is it in the evening that you are taking it? So shift to morning, all those aspects of, so that we are trying to prevent the patient from a nocturnal hypertension, which is going to cause a damage. So we need to always treat a patient as a whole, keeping the clinical as well as individual aspects in mind.
The pressure is 10 consistently, 10, 12, sometimes 10, sometimes, most of the times 10. And
so what I do is if there is actual change which is happening and I find no other reason to be attributing to that, I will give them, say, something like a brimonidine, sorry, not brinzolamide, not brimonidine, brinzolamide, and twice a day. And because the propensity of this to decrease the IOP is less, they are supposed to increase the ocular blood flow. Whether nothing is proven, but I would do that.
And when would you say it's an actual change? 5%, 10%, 20%?
Come again?
When would you say that there's an actual change? A 5% change would be actual change, or you wait for more?
We actually don't quantify the change in percentages. We would see if there is a visual field.
No, there's no visual field loss.
Okay,
There's no
in the
visual-
OCT, if the change is 10 microns, then only it is a change. Because when one goes down to seeing, if you just compare, previously it was green, today it's become red, but you actually see the numerical difference is only that it was 72 microns then, and it is now 67. So the difference is only of 4 or 5. I will not say this is
Got it.
protection.
Thank you, ma'am.
Your questions have been very bright, and
I'm a hardcore retina surgeon.
great.
So that was a very important fact that, ma'am, you told, that we have not just to look at the colors, like you already said in your presentation. It is also the numerical values that have to be considered. Ma'am, what is the role of OCT, retinal nerve fiber layer, in cases of neuro-ophthalmology? For glaucoma, we have a very clear-cut inclination towards getting OCTs done. But do you think it is helpful for neuro-ophthalmology diseases as well?
Very much. In fact, my last year's GuruSangam lecture was on OCT in neuro-ophthalmology. For every patient who comes to us with decreased vision, we offer neuro-ophthalmological cause. We should have a baseline, whether it is drug toxicity, whether it is IIH, whether it is any intraocular tumor, whether it is especially pituitary or cranial, any cellular tumor. Also, for any, there is also, it's been established that there is a retrograde thinning. So even if you sometimes have, say, a thalamic infarct, patient would tomorrow, after some 4 or 5 years later, may have an RNFL thinning. So there is, in my usual practice of a neuro-ophthalmological workup, unless it's totally an oculomotor thing, we always include an OCT. And in OCT, it is not the superior inferior, but it is the temporal and nasal. The temporal is very often decreased. Also, we are able to rule out things like optic nerve head drusen, and those will have, and maybe it could be a BRVO for the retina people, and then you do a HFA, and there was a nice arcuate defect. So one needs to correlate all these things. Do not get so even in Alzheimer's, they have found that there is thinning, and the neurologists are not. I wish there would be some neurologists who would be ready to partner with me and do this study as to we can take up people, say from 60 years, 65, 70, and see how their longitudinally the thinning has occurred in their RNFL.
That would be a very interesting research, ma'am.
Even in Parkinsonism, they are saying that there is thinning.
Yes. Thank you for the extensive coverage of the topic. May I now invite our next
Thank you
speaker,
so much.
Dr. Indu Pandey, ma'am. She would be speaking on Meibomian gland dysfunction, its diagnosis and treatment. And it's a very hot topic nowadays, considering the AQI in most of the Indian states is bad and the dry eye symptoms are not going anywhere. Welcome, ma'am. Over to you, ma'am.
Thank you so much, Dr. Kanika. So I'll be beginning my presentation now. Good morning, everyone. At the outset, I would like to thank AIOS and Dr. Santosh Navar sir for giving me this opportunity. Today, I shall be talking on Meibomian gland dysfunction, diagnosis and treatment. There are nil financial disclosures. Meibomian gland dysfunction is a primary contributor to dry eye disease, and yet it remains one of the most inconsistently taught topics in postgraduate ophthalmology. In this lecture, I will not attempt to restate the textbook descriptions. Instead, I will draw on the anatomical and physiological foundations which have been established by the International Workshop on Meibomian Gland Dysfunction and integrate them with the evolving clinical frameworks of TFOS DUCE 2 and the more recent DUCE 3 report published in 2025. Meibomian gland dysfunction is a chronic diffuse abnormality of the Meibomian glands, which is commonly characterized by terminal duct obstruction and or qualitative or quantitative changes in the glandular secretion. This may result in alteration of the tear film, symptoms of eye irritation, and clinically apparent inflammation and ocular surface disease. Now, this is the definition which was proposed by International Workshop on Meibomian Gland Dysfunction, and it remains foundational even today. There are several important teaching points embedded within this definition. First, MGD is described as a chronic and diffuse abnormality, which immediately tells us that this is a long-standing glandular disease process. Second, we see that the definition emphasizes terminal duct obstruction and altered glandular secretion. And this highlights that dysfunction may arise from mechanical obstruction, altered meibum composition, impaired delivery, or a combination of these factors. And third, the downstream consequences are clearly outlined. Alteration of the tear film, symptoms, inflammation, and ocular surface disease, reinforcing the concept that MGD begins at the level of the gland, but eventually manifests at the level of the ocular surface. TFOS DUCE 3 does not replace this definition, but expands our understanding of how these glandular abnormalities disrupt ocular surface homeostasis. Now, this schematic represents the classification of Meibomian gland dysfunction as proposed by the International Workshop on MGD, and it remains the most comprehensive biological framework for understanding the disease. At the highest level, we see that MGD is classified based on the meibum delivery to the tear film, broadly into low delivery and high delivery states. The most common form we encounter clinically is low delivery MGD. Low delivery MGD includes hyposecretory and obstructive mechanisms. Obstructive MGD is the dominant phenotype in routine practice, and it may be cicatricial or it may be non-cicatricial. High delivery or hypersecretory MGD is less common but important to recognize because here there is excessive lipid which is produced and it is of abnormal quality and may still destabilize the tear film. Now we come to the lower part of the diagram, which reminds us that regardless of mechanism, the downstream effects are similar. That is, there is alteration of tear film, there is eye irritation, clinically apparent inflammation, and eventually ocular surface disease. The prevalence of MGD varies widely, and it has been reported as greater than 60% in different Asian population-based studies. Several ophthalmic, systemic, and medication-related factors may contribute to MGD. The major ones being anterior blepharitis, contact lens wear, Demodex follicularum, androgen deficiency, menopause, aging, certain autoimmune diseases like Sjogren's syndrome, psoriasis, atopy, and rosacea. Besides that, there are medications which have been implicated, the common ones being anti-androgens, antihistaminics, antidepressants, and retinoids. And among the lifestyle-associated risk factors, extended use of digital device has emerged as the primary contributor for development of MGD and dry eye disease. So accurate diagnosis of MGD is critical because it is the leading cause of fluctuating vision and patient dissatisfaction after cataract and refractive surgery. Also, it has been emphasized repeatedly that it not only affects the ocular health, but also overall happiness and quality of life. Now we'll discuss a brief anatomy of the gland, which is a holocrine modified sebaceous gland located within the tarsal plate with its terminal duct opening at the lid margin against the globe. This anatomical arrangement is important because it places the Meibomian gland at the interface between the eyelid and the tear film, allowing lipids to be delivered directly onto the ocular surface during blinking. Physiologically, the primary function of the gland is to supply lipids to the tear film, forming the outer lipid layer. This lipid layer reduces tear evaporation, stabilizes the tear film, and contributes to smooth optical quality. Normal gland function therefore plays a central role in maintaining ocular surface homeostasis even when aqueous tear production is normal. This explains why patients with MGD often have normal Schirmer values, and yet they demonstrate tear film instability and fluctuating vision. In other words, the gland is not accessory to tear film function, it is an essential part. Now we come to the pathophysiology. When normal Meibomian gland function is disrupted, this physiological role in tear film stabilization begins to fail. There are alterations in meibum composition. There is increased viscosity of the meibum, which causes stasis of meibum, increased pressure in the ductal system, dilatation of the ductal system, and eventually atrophy of the secretory acini. And that is the late stage. And at that time, the disease becomes reversible. Also, the immediate consequence of this impaired lipid layer is increased tear evaporation and tear film instability. And with ongoing stability, the ocular surface is exposed to repeated stress, leading over time to inflammation, epithelial changes, and patient symptoms. Importantly, what we see is that T4's Deuce 3 emphasizes that this sequence represents a loss of tear film and ocular surface homeostasis, and that functional gland dysfunction may be present well before irreversible structural gland loss becomes apparent. This concept is critical for postgraduate teaching because it explains why early MGD is often functional, clinically subtle, and potentially reversible. So that underscores the importance of early diagnosis and treatment. At this point, it is also worth asking as to why it is so frequently missed in routine clinical practice. Because first, early MGD is primarily a functional disorder with altered meibum delivery. And it is so often before visible structural changes develop. Secondary symptoms are often frequently precede the obvious clinical signs. And thirdly, at this stage, initial stage, mild to moderate disease, the dead margin appearance may be deceptively normal. And third, finally, what happens is that there remains a persistent tendency to attribute the dry eye symptoms primarily to aqueous deficiency. For these reasons, contemporary diagnosis of MGD must begin with symptom assessment before proceeding to objective testing. So in contemporary practice, and as emphasized in Deuce 2 and reinforced again in Deuce 3, the diagnosis of dry eye disease, including Meibomian gland dysfunction, which is the major etiological driver for DED, it must begin with structural symptom assessment, and symptom is now mandatory for diagnosis. This is not optional, and it is not merely a screening step, it is foundational. So questionnaires such as Ocular Surface Disease Index, OSDI 12, or DEQ5, these are the validated questionnaires. They allow us to systematically capture the patient's symptom burden and the functional impact of the disease. However, now we have a shortened questionnaire, that is OSDI 6, which has been proposed by Deuce 3 to be used. An important teaching point for postgraduate here is that symptom severity does not always correlate with the extent of observable clinical signs. An early Meibomian gland dysfunction may produce significant symptoms driven by tear film instability, even when surface staining or lid margin changes are minimal. For this reason, Deuce 3 reinforces that symptom questionnaires should be used to establish clinical relevance and to justify further diagnostic testing, rather than to grade disease severity in isolation. So once symptoms are documented in a structured manner, the next step is to objectively assess the tear film stability. In MGD, reduced liquid delivery leads to increased evaporation, making tear film instability one of the earliest and most sensitive objective findings. In both T-Force Deuce 2 and reinforced again in T-Force Deuce 3, non-invasive tear breakup time, that is NIBUT, is preferred wherever available. The rationale is straightforward. NIBUT assesses tear film stability without disrupting the tear film with fluorescein and therefore better reflects the physiological state of the ocular surface. So a tear breakup time score of less than 10 seconds is positive. And when NIBUT is not available, conventional fluorescein TBUT remains acceptable, but it must be interpreted with an understanding of its limitations, including reflex tearing and examiner variability. The key teaching point here is that instability confirms functional disease even when surface staining or structured gland loss is not yet apparent. So once tear film instability is demonstrated, the next step is to assess the impact of the instability on the ocular surface using the vital stains. Fluorescein staining primarily highlights epithelial disruption, while lissamine green or rose Bengal identify areas of cellular stress and mucin deficiency. From a DUSE 3 perspective, it is important to understand that ocular surface staining reflects the consequences of tear film instability and not the primary glandular pathology itself. And in MGD, staining patterns are often variable and may be absent in early disease, despite significant symptoms and reduced tear film breakup time. So as disease progresses and tear film instability becomes chronic, surface staining becomes more apparent, particularly in the interpalpebral zone. And here I would like to emphasize that the absence of the staining does not exclude clinically significant MGD, especially in early or predominantly evaporative disease when the disease is in a reversible state. DUSE 3 reinforces that staining should be interpreted as a marker of ocular surface stress and loss of homeostasis and not used in isolation to diagnose or exclude MGD. Now, ocular surface staining can be graded using standardized systems such as the Oxford scale or the NEI scale. These grading systems are used primarily for documentation, not actually in clinical practice, but for comparing if you have to compare the severity across visits and for monitoring response to treatment. From a DUSE 3 perspective, it is important to emphasize that staining scores should not be interpreted in isolation. High staining grades generally reflect more advanced or sustained ocular surface stress, but lower or absent staining does not exclude clinically significant disease, particularly in early or predominantly evaporative dry eye. Therefore, staining grade should be viewed as supporting information, interpreted alongside symptoms, tear film instability, Meibomian gland function, rather as a standalone diagnostic criterion. After symptom scoring, we come to the slit lamp examination, which earlier used to be a backbone for evaluation of MGD. However, in present scenario also, the importance cannot be ruled out. So here we have to look for foamy tear film discharge, for rounding of lid margins, look for dimpling, notching, pitting, hyperkeratinization, vascularity of lid margins, blepharitis, tenderness to touch, and look for dischiasis, etc. One can also document these findings with high resolution slit lamp photography if possible. Having assessed the symptoms, tear film stability, and surface impact, we now come to the core of diagnosis. That is evaluation of Meibomian gland function itself. The final and the most critical step in diagnosing Meibomian gland dysfunction is direct assessment of the Meibomian gland themselves. Gland expression allows us to evaluate functional output, especially the ease of expression and the quality of the meibum which is delivered to the lid margin. Normal meibum is clear and easily expressed, whereas turbid, thickened, or toothpaste-like secretions indicate gland dysfunction even when the lid margin appearance is relatively normal. Now, a word about meibography. Meibography provides information about structural status, demonstrating gland shortening, distortion, or dropout. Structural changes reflect reduced gland reserve and have prognostic significance, but they do not necessarily indicate current disease activity. A key teaching point here is that meibography complements but does not replace functional assessment. In clinical practice, diagnosis is established by integrating the symptoms and one of the signs supporting tear film stability or surface findings, and direct evaluation of gland function. with structural imaging helping only to guide expectations regarding reversibility and long-term management. Now we come to the principles of management. Management of MGD must be grounded in an understanding of the etiological driver identified during the diagnosis. The goal of management is not merely symptom relief, but restoration of ocular surface homeostasis and preservation of gland function. Treatment should therefore be mechanism-based, it should be individualized and staged according to functional impairment rather than structural appearance alone. Again, here a key teaching principle is that the management progresses from foundational behavioral measures to gland-directed therapy with pharmacological interventions used in a supportive role. Management of MGD should begin with lifestyle and behavioral modification, which form the foundation of all the subsequent interventions. Blink optimization is particularly important, especially in patients with prolonged digital device use, where incomplete blinking and decreased frequency of blinking contribute to functional obstruction and tear film instability. Regular screen breaks and ergonomic adjustments help reduce evaporative stress on the ocular surface. Lid hygiene supports the lid margin environment and may reduce secondary inflammatory load. Besides that, improvement in nutritional factors, including omega-3 fatty acid supplementation, may have a supporting role in improving mebum quality in selected patients. Although these measures are often underestimated, DEWS 3 recognizes that they directly influence disease drivers and should be addressed early in management before or alongside more targeted therapies. Now, once foundational measures are addressed, management must directly target the Meibomian gland obstruction. Warm compresses over the lids remain the first line gland-directed therapy. By applying heat to the lids, mebum viscosity is reduced and ductal patency is improved, facilitating lipid delivery during blinking. However, the effectiveness of home-based warm compresses is often limited by variability in temperature, duration, and patient compliance. Hence, device-based thermal therapies are there, and they represent a structural escalation of the same principle. Controlled heat delivery, often combined with standardized gland expression. From a DEWS 3 perspective, these devices do not induce a new mechanism of action. Rather, they aim to deliver heat and expression in a more consistent and reproducible manner. Their role is best understood as an extension of warm compressed therapy, particularly in patients who remain symptomatic despite appropriate first-line measures. Now we come to adjunctive medical therapy, which plays a supportive role in the management of MGD. Lubricants, particularly those containing lipid components, the lipidomimetic lubricants, help stabilize the tear film and reduce the evaporative stress, but they do not correct the gland dysfunction. Inflammation is now recognized as an important and sometimes early driver of Meibomian gland dysfunction. While obstruction initiates the disease, inflammation accelerates gland damage and amplifies the symptoms. So short courses of topical steroids, particularly soft steroids like loteprednisolone, may be used to rapidly suppress active lid margin and ocular surface inflammation, particularly in symptomatic patients with significant hyperemia or ocular surface staining. These agents, however, should be used judiciously and for limited durations. For longer-term control, topical immunomodulatory agents such as cyclosporine A or levetiracetam are appropriate, especially in patients with persistent symptoms, ocular surface inflammation, or associated aqueous deficient dry eye. Systemic agents such as oral doxycycline are reserved for selected cases given their side effect profile. and they are limited to those who are having significant inflammatory MGD or rosacea-associated dry eye disease, and they are used primarily for their anti-inflammatory and lipid-modifying effects. So to summarize, effective management of MGD requires identification of the dominant etiological driver in each patient. Intervention should prioritize restoration of gland function and tear film stability, with pharmacological therapies used to support this process. Structural findings guide the prognosis rather than dictating the treatment. Setting realistic expectations with patient is essential, particularly in chronic or advanced disease. So when MGD is approached as a gland-based disease with identifiable drivers, both diagnosis and management become logical rather than empirical. So the key message is MGD should be understood and taught as a primary etiological driver of ocular surface disease rather than as a secondary lid margin finding. Early disease is frequently functional, characterized by tear film instability and symptoms, and may be present well before irreversible structural gland loss occurs. And for this reason, contemporary diagnosis must begin with structured symptom assessment, followed by targeted evaluation of tear film stability, ocular surface impact, and direct assessment of Meibomian gland function. Management in turn should be mechanism-based, prioritizing restoration of gland function and tear film homeostasis, with pharmacological therapies used as adjuncts rather than substitutes. And when MGD is approached in this manner, diagnosis and management becomes logical, reproducible, and clinically meaningful. So these are the suggested readings which form the biological and clinical framework underlying the approach discussed today. Thank you for patient hearing.
Thank you so much, ma'am. That was a crisp and concise way of defining meibomian gland dysfunction and its identification as well as treatment. May I request Dr. Ruchi, ma'am, to share her insights on the topic?
Yeah, a very nicely, extensively covered topic. Just to add a couple of practical tips, like I come across a lot of referrals where we have MGD, but we tend to overlook that the inflammation is going to involve the entire ocular surface. So you should always have a good look at the nasolacrimal duct obstruction also in these patients. In fact, I had patients who were, treated for MGD for years together, and we realized that the problem was actually an NLDO. So we actually conducted a study where we, after the pre and post DCR, we found that the clinical symptoms had improved tremendously. But on meibography, the gland dropout, which she had correctly mentioned, the anatomical dropout did not reverse. And studies have shown that even if the 50% glands are functional, that's adequate for actual functioning of the tear film stability and all that. So these are a couple of things which one really tend to see. And the other thing I find is that once the ocular surface, it may be a primary MGD, and then the ocular surface tends to get affected, there is also inflammation of the punctal lining. So these patients ultimately they may present with punctal stenosis, and we may have to go in for punctoplasties and stents. But what is important is that besides going into these surgical interventions, you should definitely take care of the treatment of MGD alongside. Otherwise, these problems will tend to reverse. So these are a couple of tips, practical tips, which I wanted to share.
Definitely, ma'am. And like you said, unfortunately, residents, they just jump up and they just want to just see the lens and the optic nerve, and they most of the times do not pay attention to the ocular surface or even the adnexa for that matter. May I request Dr. Thakur, sir, if he would like to say something on the topic, sir?
No, I don't have anything to add. It has been very nicely covered.
Can I ask
Dr.
something, Kanika?
Chinmay, ma'am? Yes, sir. Please, sir. Piyush, sir, you may go ahead.
Dr. Chinmay can go ahead.
Please go ahead. I was setting up the PPT.
Okay. So, very nice presentation, Dr. Indu Pandey. a lot of things that I learned, some yet to learn. So I wanted to know more about these humidifying glasses. Are they similar to these swimming goggles that we use, or are they something different? Because I haven't seen them.
Even I have not seen them practically, but I had a look at them from the Google. So they do have this side panels which covers the eyes.
So you mean to say like the ones that we use post surgery, or you mean that
Sim
they will
yeah,
cover the entire skin this way, like just like your swimming goggles?
it is supposed to cover your eyes all around
Okay,
so as to retain the moisture.
very interesting. And what about medication, selenium sulfide? I haven't heard of that before as well.
Yes, it has got a mention in Deuce 3 report, and still it is not FDA approved. And studies have been, they say that there is improvement in the OSDI scores, there's improvement in the lipid layer thickness following twice daily administration. But again, the long-term studies are awaited, and we need some more results to put them into practice. So that is why I didn't elaborate about that. I just put a mention that selenium sulfide, though there are a lot of emerging therapies which they have mentioned in the Deuce 3 report, but they are not yet into practice. So I thought it worth mentioning these two because they have got positive response quite, and they maybe in a couple of months or so, they may be in around the corner, and we may be having to use them.
Okay. And what about these drops that are being promoted, which are of course commercially available, like from Sun Pharma, called Sequa, and Lifatirust from a couple of companies? Do you think they have a good role in MGD?
As far as the studies have shown, they do have a role, but I have not used lifitegrast myself. But they do have a role as far as the studies which they have emphasized.
Thank you.
Thank you.
Can I ask one? Yeah, so what do you think is like, I have seen practically they're doing IPL and, as you said, that doing these therapies in the clinic, they are more concerted and are more effective rather than giving home therapies. But what do you practically suggest in our scenario? Like, what should be the protocol? How frequently is these? Because these therapies at clinic, they cost a lot. So these patients, how do you practically manage these patients?
Actually,
Apart from Western, yeah.
Actually, madam, it becomes very difficult to convince those patients who have got completely atrophied glands. Like I have a few patients of rheumatoid arthritis who are in advanced stages, and they have to undergo cataract surgery, and they have got completely atrophied glands. So for them, the ocular surface is really bad, and in those cases, we can give them Iflomax, we can give them good preservative-free lubricants, and that is what improves the symptomatology. But as far as going safely for the surgery after doing these IPL, I don't think they have any regenerative effect. So as I emphasized in my talk also, they are effective only in the early stage of the disease when the structural dropout has not occurred. Though they are being prescribed because the clinics and the which are having those who have acquired these, they are prescribing to patients, and we need to see how it actually helps the patients. But once the glands are lost, regeneration won't help much. And anything which is automated is, of course, better than the at home therapies. So, it is a game of the money. If the patient has, they can go ahead with the treatments because eventually warm compresses forms the basis of therapy in MGD.
And can I add to that? Ruchi
Yeah.
ma'am, I have three colleagues, cataract refractive surgeons who have severe dry eye, severe MGD, and all three of them have IPL in their clinics. So they've been trying, they've tried everything. And then what their feedback was that they've had IPL done to themselves, and the effect lasts for a couple of weeks, and then they have to go for another repeat session. So that is, it's not a permanent solution, despite the fact that they are doing warm compresses. I really don't know how compliant they are themselves, but that's what they say, that it lasts for a couple of weeks and then they have to go for a repeat session.
Yeah, I agree with you because patients are actually quite happy for at least 3 to 4 weeks. So, but yeah, it's a cost, recurring cost that you add to the patients, but it is effective. No, needless to say, I've seen it practically. Yeah.
Correct, sir. Even in our practice, we have noticed that what we do is generally we give them 3 sittings. at an interval of a fortnight. Like every 15 days, there are 3 sittings that are given for the IPL, and then we let it be. And we have seen our patients having good response and clinically, symptomatically more relaxed ocular surface for up to a period of 6 months to 1 year also. So if needed, we can repeat it after 6 months or 1 year also. But definitely there is a reduction in the vascularization around the glands on the lid margin. This is based on my own personal practical experience, but of course there is no set pattern to how you have to give these therapies to the patient and how everyone would respond. We've also done a few cases studies where we have actually done the meibography before an IPL therapy and after the IPL therapy, just to see how symptoms are improving and are the glands improving. Like ma'am said, the dropouts cannot be improved, they cannot be regenerated, but we can see there is a definite reduction in the tortuosity and the thickness of the glands on the meibography itself after, each session of the IPL. Symptomatically also patients do respond well. Meenakshi ma'am,
And
I think you were wanting to ask something.
Yeah, I just wanted to know the comments of the panel about people using those blue glasses, and are they actually, do they make any difference? Because I have not found, and I don't recommend. So everybody
same
is
here.
saying a no.
Likewise, ma'am.
I think,
Yeah.
ma'am, they work more as a placebo because half of the population nowadays are stuck to their laptop devices or their screens for any kind of professional and personal requirements. So it just gives them a sense of, safety that, okay, we are using the computer glasses as
Psychosomatic,
such.
just psychological.
And
And
one
one
more
more
question.
thing.
Yeah, sorry, ma'am. Sorry, ma'am. Please go ahead.
And okay, if you see a foamy discharge, foamy tear film, what is your change in the line of management? Dr. Ruchi and Dr. Indu and
Uh,
Dr. Sika.
Ma'am, I think I would add a course of systemic antibiotics. I don't know how frequently all of you are using, but I would definitely, like, the genes would vary weekly, azithromycin a gram to 6 weeks, to sometimes I give doxycycline for 10 days to 2 weeks. Along with that, I add warm compresses and azithromycin locally. So that kind of works, but nothing is foolproof. Like, I am still, at loss to really treat these patients who would be comfortable lifelong. You can just suppress it for a while, but they keep coming back to you. That's a problem. I agree with you. Those for me, that means that ear film has become more unstable. That's a kind of indication. So I just add these. These are all
So you give
trial and error.
erythromycin itself,
Azithromycin,
azithromycin,
systemic.
as a weekly dose, you said?
Yeah, ma'am. Yeah.
Okay.
Yes, azithromycin has been recommended, oral azithromycin, 500 on day 1 and then 250 for the next 4 days.
Different regimes are there. You can,
Yes,
whatever.
that is the systemic one. And then topical azithromycin can always be given for decreasing the antimicrobial load on the lids.
Yeah.
So again, as ma'am said, there is no foolproof thing, but then we should be knowing what we have in our armamentarium. And depending upon the patient, we can individualize and we can help our patients.
And can
And
I
it is
share
a,
my sorry, ma'am, please go ahead.
and it is a recurring thing, so patients keep coming for the same complaint, but we have to give symptomatic relief. That is what we have to do.
I had a patient recently come in again, chemical industry owner. So he's in a hot environment all the time. He's been troubled with dry eye for a fairly long time. But recently, like a couple of months, not recently, a couple of months back, he came back with the exact foamy appearance that Professor Meenakshi spoke about. And I had given him azithromycin topically. He comes back a week later, disturbed, saying that it's not helping me, it's not helping me. So then I asked him to start doxycycline orally, of course, low dose. And I asked him to take it for 2 months. He comes back again after 2 or 3 weeks, says that it's not helping me, it's not helping me. So I said, how consistently did you take it? He said, I took it a couple of times. So then I asked him to religiously take it for 2 months. And he just came back last week. I think he was far better as compared to before. I think the time over here is also important, and the consistency with which they are compliant is also very important. They do respond to doxycycline. This is what Dr. Sangwan also would emphasize on, is that if they are consistent with the oral antibiotics, especially doxycycline low dose, because the systemic side effects are less, they do respond.
Dr. Ruchi, you were saying something when I cut you.
No, ma'am, I was talking about the same thing. Like I do believe that long-term systemic therapy, antibiotics, they do have a role, but then I have not proven it on by any research or something. But yeah, and warm compresses along with the azithromycin topical application, the ointment topical application also helps. So a combination of all these have to be kept. Only thing is, I really am at loss to getting those dry eye test reports. The patients, they just throw those reports in front of you and say, "Ki, this is the." I actually am. I don't think that they are of much use, truthfully speaking. Those dry eye test reports recurrently being done, they have what you see clinically is far better than what those reports show.
Actually, I would like to point out here that we have to see for the signs of inflammation in a subtle manner. If we have signs of inflammation, then a short course of steroids does help the patients. And they do report that they have
Yeah.
got relief, and then they can continue with their usual warm compresses and lipomimetic lubricants or
Yeah.
high viscosity lubricants.
Yeah. So I was wanting to say something. Yeah. Yeah.
Dr. Balasubramaniam sir,
Yeah,
please.
regarding Meibomian gland disease, again, this one thing which is overlooked during a preoperative workup, and many times patients have this, and we're more concerned about cataract and postoperative. They have a lot of irritation, even with 6/6 unhappy. So preoperative workup, not in a routine patient, even for preoperative workup, especially I tell my postgraduates, make sure rule out MGD, sort it out, and before taking up for surgery, because I always tell the patients problem diagnosed before surgery is patient's problem, diagnosed after surgery is surgeon's problem. So usually they attribute it to the surgery. Next, one question to Dr. Indu madam. You mentioned about intraductal probing, maybe ductal. I'm not done. Do you have any experience?
Again,
So how do you do it?
Yes. Again, intraductal probing I have not done because it has not been yet approved, and it has to be meibography guided. Meibography guided intraductal probing is what has been talked about. So again, approval is not there. So, and it is in advanced stages when the obstruction is fixed. So we have to see again how it goes ahead and how we include this later on.
I have done that, sir.
Okay.
Because there would be patients, especially when I was working in the government setup, we did not have access, like all these therapies are going to cost a lot. So we, in very severe cases where, of course, I agree, when the dropout is total, then it's not going to work. But if you have still some hope, then uh, under microscope we tried opening those with a 26 gauge needle. We tried opening those small openings, and then followed by the warm compressors and all that. So they had a similar temporary relieving effect as you would get with those IPL and all those therapies. So it does work, but of course it's kind of very invasive, and it's too much. A lot of effort has to be put in to do those kind of therapies. So, but they do work.
Thank you.
Thank you all the panelists for such a detailed discussion. May we now proceed to the next talk of the session. Dr. Chinmay ma'am will be taking us through the art and science of suturing, a must-needed subject for all the residents, and I think for a few of us here as well. There's no harm in learning it again. Over to you, ma'am.
Yeah, thank you very much, Dr. Kanika. And at the outset, is my slide visible?
Yes, ma'am, your slides are visible. You would need to go to the
Okay.
presentation mode.
Right. Yes, so I'll be talking about the art of suturing. Part of the science I have left, because most of us are scientists, and we think the art part is not really required. At the outset, a big thanks to Dr. Santosh Honavar for conceiving this idea of GuruSangam, where a lot of postgraduates are getting helped, and to all the moderators and the expert panel on this session and my co-speakers. There are no financial disclosures. A couple of pictures of sutures I'm putting. I do not have any financial disclosure to make. So, like I told, suturing is an art, and definitely there is science involved, but mostly any work of surgery, it's more like an artist's job. And why is the suturing very important? It is because the suturing definitely affects the functional outcome of the surgery. And the outcome basically as scar after 3 to 6 months of the particular surgery, it affects the scar and finally the patient satisfaction. However well the surgical outcome is and the scar, patient will be bothered by what is seen on the surface. You did a wonderful DCR surgery, but then you got a scar on the face. Patient will not be happy. So for these three things, we have to learn both the science as well as the art. Now, to reiterate the same things, I'm going to take you through three scenarios. This is a uncomplicated cataract surgery done, and the next day, this is how the patient comes. If you look very closely, you can see this small hypopion that is there, and this is endophthalmitis. And why did the endophthalmitis happen? It is because of this leaky wound, clear temporal phaco, a very tiny leak at the time of procedure. Just think that, okay, I will get away with this. But then that one single suture has led to a very devastating outcome. From 6/6 to endophthalmitis, nothing can reiterate the fact that a single suture can turn the table around. So this is one case which I wanted to show how the suturing affects the functional outcome of a surgery. The next thing is after 3 to 4 months of age of the corneal tear repair, what is the astigmatism that comes? So that is the next thing. And a lid tear sutured leading to a cicatricial ectropia. During the follow-up care, if we did not do, if the patient did not apply the ointment, steroid ointment properly, or if he has a tendency to scar, then again the patient is bothered cosmetically. Contrast to this patient who is a post DCR on the very next day, who is doing very well, and you can't even look at the scar because we made use of the science and the techniques. We made use of the Langer line. We made use of very fine tissue handling. We made use of good equipment. So that is how the whole thing changes when you use all the right armamentarium. So I will be dividing this talk into the following topics. So I just gave the introduction. I'll be telling you the functions of suturing, and then we will go into the sutures and needles and the types of suturing, and then the technique itself. I purposefully kept this talk very basic for the purpose of postgraduates. I haven't put real suturing videos mostly, but I'll be using like the old time chalk and handwritten drawings. So what is a good suturing technique? Where there is very minimal tissue manipulation, you use a proper surgical technique and you use the proper appropriate instrumentation. So what do I mean by tissue manipulation? It is the finger pressure that goes into holding your instruments and holding the tissue. What makes a good surgeon's suturing different from a very first year resident is that their fingers are trained. I used to learn the keyboard, and the amount of finger exercises that they used to tell. I now also tell my postgraduates to include some kind of finger training. Like it could be drawing simple lines on a sheet or doing any of the finger movements. So these give stability to the finger and dexterity to work with. This is the most important part for a postgraduate student, whether it is for your cataract surgery or for suturing or for any surgery. Our fingers are the most important thing, and we have to train the fingers to do well. So you have to become an artist. Like the amount of time artists put into their work, that is how their work becomes so good. So the first thing is to train your fingers to reduce the pressure in holding the tissue, because how hard or tight you hold the tissue, you are in turn causing damage to the tissues. So one is the tissue trauma that has already happened, and then your handling pressure will add on to the healing process. The next thing is the art of the surgical technique, and the technique is everything. Okay, so that is the basis of good physics of your wound healing. So that we will deal later. And the instrumentation, we should have good instruments. I cannot be using very large needle holder for a 10-0 suture, or I cannot be using a non-tooth forceps to hold the edges of skin. Okay. So depending on what tissue you're holding, what suture you're holding, you have to vary the instruments accordingly. We cannot have one needle holder, one forceps, and one scissors for all. You have to vary between the different types of needle holders, the different suture tying forceps, the tooth forceps, and non-tooth forceps. We change accordingly. And whenever there is an opportunity to plan the incision, corneal tear patient has come, you do not have an opportunity to have the your way you wanted the tear to be. But when you want the planning the surgical incision, like in this case of DCR, this was like a very old picture where we used to put the incision like according to the textbook 1 centimeter from the medial canthus. The olden time, gone are those days. Now we use a subciliary incision along the lid crease line. So see, that makes a lot of difference. So that also pre-op planning of your suturing is also very, very important. So what are the common scenarios that postgraduates usually get is mostly at the end of surgery, surgeon has finished the surgery, okay, close it up. Or a large, very bad tear, no vision potential, okay, you do it. So very, very small tears, or when you had a complication of cataract surgery, you had to close the wound, corneal tears, and in trauma. So most of these are the more common situations. In my institute, mostly PGs get to do skin suturing a lot on their own, and some uncomplicated corneal tears, very bad tears. So these are the things that PGs most usually do. So I put that. Many a time patients are already sutured like this and sent for the eye management, and that is when you also have to consider reopening these sutures for a better cosmesis and redo the sutures. Now, functions of suturing. So what does the sutures do? They provide strength to the wound. So how till the body's natural collagen comes in and maintains the tissue integrity, the sutures take the place of the natural healing, hold it, and in the interim period is when they actually provide strength. Finally, the body heals itself, but then sutures are an aid to heal to give strength. During a corneal or a scleral or a cataract wound, they give watertight closure and they prevent infection from coming into the eye. In terms, so there are two types. One is the oppositional wound closure and one is the watertight closure. So in the cornea, we need the watertight closure. And in the skin, like in upper lid ptosis surgery, we just need an opposition. We don't need a watertight closure in an eyelid surgery. Same way, we don't want opposition in a corneal wound. So what is the function? Why are we putting the suture? You have to understand. And then they approximate the edges so that scarring, the final scarring, whatever comes, is reduced. So if the sutures are not put, it heals on itself and gives rise to a lot of scarring, particularly if the visual axis is involved. We want minimal scarring to happen. So a good opposition is what we want. And like I told, it prevents infection. It eliminates dead space where the fluid and bacteria collect, as in terms of skin. But in our cornea and conjunctiva, the contaminants can enter in from a leaky wound. So these are the main functions of the suture. And of course, reduce scar formation, because finally, whatever this patient does not understand, patient only understands what is seen on the face finally. So coming to the sutures and needles, there are a host of sutures and needles. I have a kind of going back to the Bailey and Love days where that was the first introduction to sutures and needles. And when we have a suture, what are the things that we consider? The material, what is the absorbability of the suture? Is there any coating on that? And the construction. Okay. And of course, the needle. So on the box, we have all these things written. So 60, it is the number. Okay, so when we go for this indicates what is the thickness of the suture. So lower the number, the thicker is the suture. So if I tell 10 O, then it is very, very thin. And then this is the, again, what is the needle type? It's a spatulated needle. What is the tip? Again, I'll come into details of that. This is the material, commercial name Vicryl, but actual name is polygalactin. Then what is the dye? That is violet. Why are some sutures dyed? Particularly in ophthalmology, we need dyed tissues. Once I got an undyed nylon 10 suture for SFI and the trouble that I had in the undyed suture, God only knows. And from then onwards, it's like always mentioned that you want a tinted suture, okay, particularly because our tissues are transparent and braided, and it's an absorbable suture. And then you have the total length, and you have the whether it's a double-armed suture or a single-armed suture, and the curvature of this needle. So all this, everything is written on the box. We just have to read it. Moving on to the next categorizing the suture materials. One is absorbable and non-absorbable. Are these markings still visible on the screen?
Yes, ma'am, they're here.
Okay, I think I'll just have to erase the markings. Oh, okay. I'm so sorry. I'm just taking some time for this. Okay, nevertheless, I'll just do that. So depending on the suture material, we have absorbable and non-absorbable. And these absorbable are broken down by the body and no removal is required. So these sutures are mostly put inside of the body, like within the skin. We use the Vicryl, or when you know that the patient will come back and you will remove the sutures, then also sometimes for the skin also we do use Vicryl 6O for DCT, DCRs and all, but remove them very early. Non-absorbable sutures are permanent, and these are for long-term structural support. So mostly in your cornea, it is mostly the non-absorbable sutures, and skin also, it is non-absorbable sutures. And why some people prefer absorbable is that they are very easy to work with, and that is when they want to use the absorbable sutures. Coming to the material, we have monofilament and multifilament. Monofilament or single strand, and here the infection risk is very, very low. As you can see, this is a monofilament, and multifilament made up of multiple strands. Because of the gaps between the suture, there is a high risk of infection. But then the suture is very easy to work with. Like if you use 6O Vicryl versus a 6O Prolene, it's very it bends easily, so it's easier to tie in a multifilament suture, and so the knot itself has very high security. So that is how the multifilament works well. And to begin with, whenever you are learning to suture, you could use multifilament for the ease of using, while the monofilament like Prolene has good memory, and it forms small knots and bends on the suture, so that may be a little difficult in the beginning. So the next thing is the considerations, what you have to do. So you have to think of the healing duration and what is the tissue type that you're using. Is it skin or is it cornea? Depending on that, you choose your sutures. What is that you're looking? Is that a knot, highly secure knot that you are using, like cornea watertight? I use a non-absorbable. Skin apposition, I can still use a very observable stitch also. It should not matter. And definitely astigmatism is the most important concern in cornea and the cosmetic outcome in terms of skin. So the size of the suture. So I'll just put in some of the sutures that are there in our OT. So mostly from 5O to 10O is what we use. Oculoplasty surgeons use 5O or even sometimes 3 Two, also, when we are doing a dermis fat graft, we want to close the big skin incisions. We use 2030 and all for the deeper bites, and then we use 5O silk or proline for the skin. And 6O, most squint surgeons use a 6O vicryl for the squint surgeries. 6O silk, vicryl or proline is used for skin closures. 7 and 8 are used for conjunctival closures. Some glaucoma surgeons use 8O vicryl, 8O ethylone, and 9 and 10 are mostly reserved for your cornea and the sclera. Apart from this, retinal surgeons also use 5O non-absorbable stitch for the buckles and all. And most of the things, these are the sutures that go with. And for scleral fixated lenses, we have a 10O nylon with different types of needles, like straight or curved needles. So while ordering the suture, please order the correct one, particularly SFI. If the surgeon wants a straight and a curved, if they send two curved needles, then again you may be at a problem at the time of surgery. So prior, decide what suture and what size and what type of needle you want. So coming to the needle tip. So this is the needle point, and this is the body, the overall length of the needle, that is what, and the curvature of the needle. And here is the suture attachment point. So these days we have a swagged end where the suture diameter is the same as that of your needle diameter. Okay, and this is the needle cord length, and this is the curvature of the needle. So we will go into the different tips of the needle and different curvature. So here, this is a half circle, 3/8, 1/4. So most of the times we use 1/4 to 3/8 of a circle. Very rarely we use the half circle as in this superior stitch. And whenever we need to do a phonics deepening stitch, we use the half circles. And 5/6 circles and all, sometimes for DCR surgery, it may be useful, but it's difficult to find the sutures. And the straight needles are mostly used for pupilloplasty and for SFI walls. And these are the tips. So the round-bodied, atraumatic, and cutting needles for the skin. The reverse cutting, where it is an apex down, and between the curved and the reverse cutting, the advantage of using the reverse cutting needle is that the tract through the skin will not expand in a reverse cutting needle, while the tract may expand in the regular cutting needle, and so your tissue may cheese well. So we mostly prefer a reverse cutting needle when we are doing the skin suturing. And other than that, the micro point spatulated, this one is mostly used for squint surgeries and retinal surgeries, where the needle has to pass through the sclera, so that in such a case, the sclera does not perforate. So in those, even the cornea, sclera and squint, we have the spatulated needles. So different types of suturing. Can I just exit the PPT? It's a little disturbing and come back. I'm not able to erase these things.
No, ma'am, you can go ahead that way also.
Yeah. I'll just reshare the same thing. Yeah. So is the slide visible?
Yes, ma'am, it's clear now.
Yeah. So the types of suturing, we'll just quickly run through this. Mostly, we use interrupted suturing. That is a simple single stitch, and these are used for general wound closure whenever we have irregular wounds or contaminated wounds, because we do not want infection to happen to the entire. Suppose in an infected wound, if I use a continuous stitch, the whole thing may get contaminated. So each stitch is individually placed, and the advantages are high control over the tension, and there is minimum risk of dehiscence. And these are it's easy to monitor between the thing. So it is just that it is going to be like this, single stitches. Okay, so this is the single stitch that we use. The next thing is the continuous stitch. In the continuous stitch, as I mentioned earlier, there is a clean tear, and you just want to do a running stitch. Okay, so this is a continuous pass that goes through the thing. And here the stitching is faster, there are less knots, and there's an equal distribution of the tension. So they tell the astigmatism is less in a continuous suture in your keratoplasty incision. If you have you do this continuous suturing, the wound tension is well distributed. So that is what is meant by the continuous stitch. Again, you need a highly experienced to put in keratoplasty. I think later the panel can discuss on that. And but I particularly like this continuous suturing in the eyelid. In your DCT, DCR, ptosis incisions, blepharoplasty incisions, I use the continuous suturing technique. The only drawback is that if the suture breaks, the entire closure can fail. So that is the only drawback with this technique. And vertical mattress stitch, particularly useful for a vertical lid tear repair. I will demonstrate this later. And next is the subcuticular stitch. As you can see in this picture, although I could have done a continuous stitch in this, we just want to demonstrate a subcuticular stitch. I did this, and you can see that hardly the sutures are visible outside, and because it's a child, and again you will need a GA to remove the stitches. So in those kind of situations, you could do subcuticular stitch. I'm not a big fan of subcuticular tissue on the eyelid particularly, because there is hardly any subcuticular tissue. Okay, so it is skin and orbicularis and levator. So I generally don't like to do subcuticular because the continuous running stitch works very well. And deep sutures, like I told, whenever we have harvested fat or you harvested skin and you want a little deep closure, we use the deep closure. What are the tips for a good closure? Always match needle type to the tissue type. Like I told, if you have skin, you have to use 6-0 suture. If you are using 8-0 suture for the skin, it is not going to hold. If you are doing a corneal suture, if you are using a 8-0 for the cornea, it is going to give you a lot of astigmatism. So do not compromise on the needle type or the suture type for a particular type of tissue. And always invert the wound edges, and to prevent a depressed scarring, avoid excessive tension and consider layered closure for deep wounds. So now, before the actual suturing, inspection is very, very important. So a wound which looks small like this may be actually very deep. So before starting the suturing, having an idea of what you are actually dealing with gives you better control over your surgery and keeps you better prepared. And whenever there is a large wound debridement is very, very important, because finally any small particles left behind will give rise to a lot of scarring in the postoperative period. Particularly trauma, good debridement is very, very essential. And foreign bodies. Look for foreign bodies. Even if nothing is there, look for it. And if it is there, look for more. Like here, I saw only one in the beginning, but then there are multiple. Nothing at all here, but then there is this. So these patients later will come back to you with abscess. Sometimes the wound of entry and the wound of you removing the foreign body will be completely different. So here, this is the corneal tear through which this foreign body has entered. After dilatation, you see it's a very large three-dimensional object, which you cannot get it out through the same thing. And then you will have to make a different incision altogether. And this is one patient which I want to tell who came back, like who has come to us like this, a wound which is healed, operated elsewhere, coming back with a brain abscess because there is a foreign body that was left behind. So that is why I thought I'll put this thing, although it is out of my purview. Moving on to the technique, it is easy to break down the steps into these parts. How to hold the needle, how to hold the tissues, taking the bite, doing the knot, and finally cut and burying the suture. How to hold the needle. So here, when you hold the needle should be stable. And how to hold your hand. Rest your hand on something. Like if you have a chair with armrest, rest your elbow on the armrest. If you do not have that, at least rest your hand firmly on the forehead of the patient so that your hands are stable. And then hold the needle at the junction of anterior 1/3 and the posterior anterior 2/3 and posterior 1/3 towards the swagged end, and so that the needle does not rotate like this. So I just show you this small video where I will show you how holding. See, if I hold, you can see how the needle is very unstable. If it going very close to the suture side. Again, where you hold at the needle holder is also very important. If you hold it close at the tip or at the back, here it becomes too tight. So even at the needle holder, you should find a perfect spot somewhere between the middle and posterior third where the stability of the needle is the highest. Okay, so it is both. Can you see? So the needle should not be moving like this. At this point, you can see the needle does not move and you can easily rotate. So the whole bite has to go in one throw. So holding the needle stable is the first most important tip to get a good suture. Next, holding the tissues. Where do we hold the tissue? Do you hold the tissue at the tear or do you hold it somewhere else? Okay. So when you hold the tissue at the cut end like this, you are actually damaging the edge of the tear. So I suggest you hold the tissue at the limbus and take a bite through and through. So thereby you reduce tissue damage to the edges of the wound, but you have good stability by holding at the limbus. And how much pressure, it's again very, very important. Like I told, the tissue pressure is what differs excellent surgeon from a novice surgeon, how gently you hold the tissue. So because that leads to the final healing. And taking the bite. So here again, I will be showing you some pictures. So if at all, if this is the tear and this is the needle, how do you take? It has to be perpendicular. Your needle has to be entering perpendicular like this. If the needle is entering at an acute angle, then the bite that you take will go like this. But if you enter perpendicularly, your bite comes like this. So this becomes good. Suppose if you enter very deep, it goes through and through, and then tissue can get infected. Okay, so the right way to enter the tissue is to go perpendicular 90 degrees and in one go. If it is corneal tissue, you have to take the whole bite in one go. If it is clearer, one side come out and then the next side. But cornea, it's always one go, one shot. And next is, this was about the depth. What I talked to you was first the depth of the tissue. Next is the length of the tissue. Okay. So first was depth. What is the depth that we go? 80 to 90%. Okay. Once you take 80 to 90%, it's a very good tissue depth. Next is the length. How much length of tissue? So usually about 1 to 1.3. This side, 1 to 1.3 this side. So that is a recommended millimeter wise, but then it will vary depending on the suture itself. It will depend on your type of the tear that you had. Okay. So the next thing is, like I told, no acute entry, and you have to go through and through. Suppose if you have uneven entry like this. So here it is half, here it is only quarter, and then your final suture will, when these things join, it is going to join something like this. So you will get an overriding edge. So that is also not a very good technique. And again, another scenario like this one, if you take this last scenario, where you are leaving a little bit of tissue on the posterior part, then the posterior part of the wound gapes. So that is also not a very good idea. And what to do when wound is not perpendicular? So when you have wound like this, I told you go like this. But what to do when wound is shelved? So at that point of time, it is not the anterior wound that determines how to take the bite, but it is the posterior tip. So these two posterior end have to be equidistant. Okay. So it will be something like this. Okay. So here it is very short distance from the cut in. Here it is a long distance. But mind you, here we are looking at the posterior aspect. Okay. So the posterior aspect has to be opposed well. So that is the thing in terms of a shelved injuries. And now coming onto the front surface, how do we put the sutures? Do we put like this? No. Here, as you can see, one suture is long and one is short, one is away. We should not put the suture like this. It should be a way when every suture is equidistant. Okay, all your sutures have to be equidistant. In terms of distance between the sutures, in terms of length also, both in length and the gaps, everything has to be equidistant. Why do we need this equidistant? Is that when we, because of the compression effect. So when we put a suture, the maximum tension that is there is at the suture. As we move away from the suture, the tension starts to decrease like this. It starts to decrease. So there is one rhombus of area where the tension starts to decrease as we go further. So when we put sutures, we need these compression boxes to overlap. Okay, so that determines your placement of suture. What is the distance between the sutures? It is determined by that. So suppose in the first scenario here, when I have put, these are very close short sutures, so more compression is happening. It's not a very good. In the second part here, when you see here, there is a gap and there is no overlap of this compression zone. So in this area, there will be a leak or here fibrosis will happen. So your compression zones must overlap. So that is your way of suturing, placement of sutures, the distance between two sutures. And direction of sutures should be same. Okay, it should not be like one is angled at 30 degrees. It should be perpendicular. Wherever is the suture wound, suture has to be perpendicular. Okay, what happens when the wound is different? Wound is like this. Then you have to change the direction. So here my sutures will be going perpendicular. Like I told, perpendicular. Here at the angle like this, and when the direction changes, your sutures also should change directions. Okay, so that is how we are going to do the placement of the sutures, this one. And whenever there is a tear extending into the limbus, first we will be putting the securing stitch at the limbus. So we will put this first, and then at the angles second, and then start putting in between sutures. So this is the thing when we have suture extending onto the nimbus. And knotting. So how to do the knot and how many throws do we do? In general, we do 3, 2, 1. So first throw, second throw, and third throw. So I'll just demonstrate these throws. And here, one thing that I want to tell is, here, can you see I'm moving both my hands? That is not to be done. At least keep one hand stable. Either the right hand or the left hand you have to keep stable. And when you do the knot, at the first instance, this knot should not form. This is the wrong way which I am showing how it should not form. The knot should not form in the first go itself, because then the tensile strength does not add up. So I will show you how it has to be done. So here I'm keeping the needle holder stable. I'm using the other hand to throw the sutures. And once the throws are done, you have to get a straight line like this. Okay. So once you get a straight line like this, your suture tensile strength you can determine whether you want it tight or you want it loose. So if a knot forms in the first go, before you take the second throw, it will become loose. And when you tie the second throw, your suture will become loose. So this is a very, very important thing that I want to reiterate. After the first throw of 3 throws, you should have a straight line. How to get a straight line? You have to change your hand. So I did like this. If I do, it will become a knot. So just change the direction. You will get a straight line. Adjust the tension of this suture. So how to adjust the tension of this suture? I will tell you. But after that, the second throw will be 2 or 1. That depends on what tissue you are doing. If you are doing sclera, it will be 3, 2, 1. Skin 3, 2, 1. But if it is cornea in the center, you don't want the knot to become very thick. You can do 3, 1, 1. Okay. So that is the thing. Yeah, I will show the knot. So after this, we will do the second throw. When you do the second throw, it has to be perpendicular to the first throw. So then again, you can adjust your hands to have a compact knot. So see, this knot has become compact. Why do I need a compact knot? So that I can bury the suture easily, so that the tract is not thick, so that the scarring is less and the astigmatism is less. So this is the most important thing. I won't go into much detail. If you learn to put one suture correctly, that is enough. Okay. So that the other things I told, how we start to put, you start to do. And I think because of lack of time, I just rush through this thing. And whenever conjunctiva is involved, expose the conjunctiva first, know the extent, and do the first at the limbal suturing, and then towards the cornea, and then towards the sclera. And whenever you reach an extraocular muscle, you have to go underneath. And I already told you this effect of the compression zones. Compression zones must overlap. That is a rule. So the zones, unless they overlap, there will be a gap and your wound will not be tight. And whenever there is tissue prolapsing out of a wound, be it vitreous or iris, it has to be depressed with a spatula. Your assistant has to depress and then you take the bite. And this is one situation where we don't take through and through. We take one bite, ensure tissue is not incarcerated into the needle, and then you take the second bite through the second tissue. So this is about the second throw from the opposite side. And when you are tying the knot, you should ensure the iris does not come into the wound. Because once iris comes into the corneal wound, then vascularization, angle closure, cataract, all these things happen. So do it right the first time you're doing. No tissue should be incarcerated in the wound, be it vitreous, be it iris. And then the knot. And this knot has to be buried. So you hold the tissue, hold the suture here and bury the knot into the tissue and then reverse so that suture removal will be easy. I think, Kritika, I will skip the videos. Mostly this must be enough. Otherwise, videos, there are multiple things that they can see. Otherwise, I'll just quickly show just one suture. So here, like the iris corollary tissue that's coming out is being reposited, and that is how the needle is held. I have supported the hand on the forehead. I've taken one throw through the sclera and then pulled it out. And take care, don't touch the tip of the needle because the needle will become blunt. And then passing the second throw, holding the tissue inside so that the uvea does not get incarcerated. And then we will take the other bite and then do the suturing. So this is what I told, whenever muscle comes, you move the muscle to the side and suture underneath the muscle. And what I was telling about checking on astigmatism during the surgery itself, adjust the tension of the suture such that this corneal reflex that you are seeing here does not get altered. Okay. So during the initial suture placement only, look at the reflection of your microscope ring or the reflection of the light on the cornea. So if this light is getting too much distorted, then the tension is too much on your suture. So in that case, loosen the suture and adjust it on table because we do not want finally a lot of astigmatism. I told about the knot burying. And whenever we are doing conjunctival sutures, we do buried sutures. And what I mean by buried sutures is that if your tissues are like this, I take inside out and then outside in and bury the knot inside. So that is the buried suture that we do on conjunctival suture because it will be irritating and we cannot bury the conjunctival suture. And moving on to skin suturing, I'll just show one continuous suture that's being done for a DCR scar. Most importantly, the wound anywhere has to be everted. Okay, wound has to be everted, particularly the skin because it's elastic. It tends to curl inside. So when tissues curl inside, epithelium is getting trapped inside. So it can lead to a lot of ingrowth of epithelial cells and also lead to depressed scar later. So your wound has to be everted like this. It has to be everted. So this is a continuous stitch that I'm showing you. And after that, it is just like how you stitch your cloth, but then ensure at each time you are everting the skin. Okay. So you can sometimes, if it's a clean cut, you can take a pass through and through, or if you want, you can take them separately. I'll just run this. So at the end of the thing, something called a skin ironing, where every time you press on the skin so that wrinkles are not formed on the skin. Okay, and keep the area clean. When you reach the end of the suture, you can reverse the throw so that kinking and wrinkling does not happen. So I was taking from top to down. Now you can see that I have reversed the needle. I'm taking from down to top so that there is no wrinkling that is forming. And you have two ends to tie on either side. The vertical mattress stitch is this. So here it is like one suture 5 millimeters away from the cut margin, goes deep into the tarsal plate, comes through the tarsal plate to the opposite side and the skin, and comes 3 millimeters. So this is also called as 5331. So here it is 5 mm, here it is 3 mm, here it is 3 and 5. So I went here inside deep, come out of the skin on the lid margin through one of the Meibomian duct orifice through the tarsal plate, and then come closer to the cut wound. It's now superficial, come out through the skin and tie. So this is the vertical lid mattress stitch for lid margin approximation. Okay, and then so this is how the final outcome would be. Whenever we have secondary repair, when sutures are done quickly at a different center, for any reason, redo the stitches, reopen everything and apply the same principles and close it up for a good cosmetic outcome. Okay, so that is all for today, and I will not be dealing with suture related complications, suture removal, astigmatism. That's a totally different class altogether. And the take home message from this class is practice makes man perfect. Practice, practice, and practice, because finally it is an art, and art needs dexterity of your hand, stability of your hand to do good suturing, assimilate the science, the techniques, and the decisions that have to be made intraoperatively. And all those techniques you have to know thoroughly. That also I could not hit on in this class. And train the mind, because finally when you are doing the suturing, it's on a live patient that you're doing. So at that time, how your mind is, how is the tension, and all that will affect your final outcome. So patience and composure most required for suturing, because sutures break. You may have put a wrong type of suturing. So you should have patience to redo the suturing once again. Even if you have to remove all the sutures, if they are not good, you have to do that, and you have to perform the best art. For all that, it is practice only. And there's no shortcut for practice, because someday you may have to do a very quick suturing, like this patient who came yesterday was post neurosurgery and he has developed exposure neurotropic ulcer, and the anesthetist is telling, I cannot give for this neurosurgery case, he's on heparin and multiple things. You have to be quick to do the suturing within 2 or 3 minutes. So all that will come by your practice. Thank you very much for the patient hearing.
Thank you so much, ma'am. And with all the clinical pictures and examples, and this was a very elaborative way of explaining how to suture properly in the clinics. May I request, ma'am, Dr. Chinmay, ma'am, can you please stop
Yes.
sharing your screen?
Oh, yes, yes. No, thanks. Yes.
And I would like to invite our panelists, Dr. Piyush sir, Dr. Ruchi ma'am, if she's around, if they would like to contribute to the suturing art and science.
Well, I don't know whether I should be proud or sorry to say that as a VR surgeon in the last decade, I've hardly put any sutures other than cases for globe rupture or for foreign body removals. But for sure, this is just like aptly Professor Chinmay, such a treat to listen to her always. It's a fantastic art to know. The topic is very apt because any surgeon who can do suturing well is going to respect tissues well. So I think that's a very important. She's covered practically everything. Maybe I can just reiterate some of the golden rules that I remember from my residency and from my fellowship days is that you have to respect the tissue planes when you're suturing. You have to always maintain symmetry, which she has shown so beautifully. You avoid, excessive tension. The suturing shouldn't come from your elbows. It has to come from your wrist. So you have to ensure watertight closure, as she's already said. And last but not the least, you have to not forget those sutures. You have to remove the sutures in time when it's indicated. So maybe perhaps the other enlightening panel can add some more points.
Dr. Balasubramaniam, sir, would you like to contribute to the topic?
Again, an excellent presentation because it's a vast topic. Just few points to add from the postgraduate point of view. Just to recommend one book called George Iser. It's called Eye Surgery by George Iser, published in 1980 and the 90. Now I think the new edition. It talks about what's called grammar of a surgery, because each step, how we hold, all the vector forces involved. I think it's a good book for a postgraduate. And regarding suturing, I think she's covered most of the things. And normal common mistake a beginner does is when they do the suture, they just try to push it, especially for microsurgery. It has to be like you have to rotate your hand like when you rotate a screwdriver. So that's a common thing. And similarly, when you do scleral buckle, you do what is called bobbing technique to prevent glow perforation. And I like the point of buried suture for conjunctiva. I was about to say that she's already covered, because many times we see even following trap or even a VR surgery, suppose they put a conjunctival suture, they take it from outside in like a routine surgery, but the suture ends up exposed. You cannot bury a conjunctival suture. When you try to do it, you'll have buttonhole. So take it from the undersurface. It invariably ends as a buried suture. And again, an excellent talk.
Yeah, I just wanted to add a couple of practical tips again. These, as she had correctly mentioned, the sutures are meant just to oppose the tissues. The wound healing is anyway going to take place. So always, it is important that these sutures should not be forgotten, because all these suture ends, they have, tendency for the biofilm to get stuck on and cause infection. So any neglected sutures tend to have more post-operative infection than anything else. Absorbable sutures, although vital, especially we use a lot of these absorbable sutures in children because they don't allow us to handle them post-operatively, but we vary that meticulous because they tend to cause more inflammation. The healing is, in fact, not as good as when we use a non-absorbable suture. So you need to keep these wounds clean and dry till the healing completely takes place. Another thing is neglected sutures, they tend to cause hypertrophic scars formation. So again, you need to keep a watch, especially when you're doing skin suturing, that these patients do not, because of continuous inflammation reactions. So not all wounds would cause hypertrophic scar, but those who have a tendency, they need to be washed early, and precautions thereon taken in care of, intra lesional steroids, or maybe we also give fluticasone. So all those things need to be taken in time before we end up into scar formations. So, and of course, the buried sutures, they are really useful not only in traps, but I have seen in plastic patients also, where, nowadays a lot of patients, they're coming in for cosmetic eviscerations and all that. And if you try to use continuous sutures, and then what they do is while cleaning, they just pull one end and the whole thing zips out. So, and if you keep the ends upwards, then these ends themselves act as a source or collection of discharge and subsequent infection. So it is very important in these patients where you give buried sutures so that you have a smooth surface on the top where you can put in a conformer and allow it to heal. So that is a little, you have otherwise completely covered all the topics very relevantly. Thank you.
Thank you.
Dr. Thakur sir, Dr. Indu ma'am, and Meenakshi ma'am, would you also like to contribute to the topic?
Yes, ma'am. I would like to add some points. Uh, I personally started doing cataract surgeries from ICC and then ECC. So we used to get lot of practice of doing suturing during those days. Unfortunately, nowadays the PGTs are only doing SICS and FACO, so they are less used to suturing unless there is a patient of trauma coming. So when a patient of trauma comes, then they are not so familiar with the sutures. That is why this topic is important nowadays. We used to do lot of suturing in cataract surgery, so we are used to it. So a couple of things regarding iris prolapse in a corneal tear. Sometimes they are quite old and we need to do iridectomy. So that is important. And we don't push the iris through the same route from where it is coming out. We make a side port and then repose the iris tissue if needed. So that is another important point. And one interesting incident I would share regarding the burying of sutures I had recently. One of the sutures, there was a problem in SICS, and one suture was given and it was not buried properly. And the patient next day comes back to me with bleeding from the eye. She was so scared. And then I saw that there was a blood clot in the fornix and there was a hyphema also, surprisingly. And I was also surprised, such a lot of bleeding. And then I did the bleeding profile of that patient, and it was a patient of bleeding diathesis, and she had a bleeding disorder which was not communicated to us, and that exposed knot tip of the suture was hitting the eyelid, and from there the bleeding started and caused the clot in the fornix and the hyphema also. Thankfully we managed it and the patient regained vision, but that is the importance of burying. Thanks a lot.
Thank you, sir. Meenakshi ma'am, I think you're on mute. Ma'am, please unmute yourself.
So just like wonderful talk, Dr. Chinmay. What I would just say, I'd like to add for the benefit of PGs is that when you hold an instrument, hold it very gently, as if like you're holding like a pianist, the person who directs the music. The way they hold the thing softly, hold your instruments very softly, because young surgeons tend to, especially since, as Dr. Thakur said, they're not used to suturing, so they really hold on to their thing. The tighter they'll hold the instrument, the chances that the needle won't go. But if you just approximate it and hold it and suture with both hands, and what she said about always giving a fulcrum to your hand which is passing the suture really helps. So whether it is your little finger which is resting on the patient's forehead, that would make what you're doing much more directed and much more easier. And the only problem I've had is sometimes in congenital cataract, for instance, you need to remove their sutures which have been put on the at the section. After say 6 to 8, you cannot remove it early. But some of them, when you're removing it at 6 to 8 months, one of the it broke partially. So the rest of is in. So I was forced to leave it in, and I'm just hope that it does not become a bed for any infection. And because by the time they come after 6 to 8 months, the tissue is, the suture is fragile and breaks without coming out in whole. Wonderful class.
Yes, ma'am. I think, ma'am, apart from the suturing techniques itself, it is also the observation skills of the students that matters. Most of the time we have seen most students don't even pull the eyelid up to see whether the wound construction was okay or anything, and they miss out on these loose sutures hanging somewhere and land up in endophthalmitis. So it is the observing skill also that matters. Dr. Balasubramaniam, sir, please go
Yeah.
ahead.
Yeah, just 2 points from the PG's point of view. First is learning the suturing. They always call it's like in tennis, you have forehand and backhand. So they're initially they do it forehand, but there are certain situations you have to do backhand. For example, you have bimanual side port and at 6 o'clock you want to suture for some reason. Then they find it difficult to practice that. So it is better to practice both forehand and the backhand in the wet lab. In different directions, they should be able to put the sutures and also make should be radial. So that has to also be practiced.
Dr. Balasubramanian, will you put it, add it in the chat box, the book that you were suggesting?
Yeah, sure. Because the reason I'm talking about this backhand, sorry. Yeah, during my post-graduation days, I did in my regional institute, MMC, Chennai. So we used to get a lot of corneas, which are not bad corneas, not good for keratoplasty. So my chief used to give it to the PGs and ask us to create a button and do the suturing, but without rotating the eyeball, so that you get the radial direction with the backhand. And only if he's convinced, he'll give us an opportunity to do keratoplasty.
Exactly, sir. It's the same thing for me also. When I was doing PG, there was no cornea fellowship. So PGs had the golden opportunity of doing penetrating keratoplasties for this corneal ulcer. And that is how we learned all the different techniques, the front hand and the back hand. And I do remember, like, whenever I'm doing the squint surgery in a very young child, particularly for the left hand medial side, when I have to take the bite, the nose comes here. And all these techniques which we learned for the keratoplasty are actually helping in corneal tear or in. So I think I want to stress the same thing what sir has told to the postgraduates. Like whatever you learn, something else will help in some other thing. So nothing is a waste during post graduation. You may be taking different specialty, but some other specialty, some technique. It's a skill, and all skills will come in your help. It's a very good point you gave, sir.
Definitely.
Just quickly add one, just for PGs, of course, is that I've had two residents come up and say that, sir, we were asked questions about the types of sutures, and we did mention everything, nylon and vicryl and silk, but what other type of sutures? And that question just kept lingering. The better you answer, of course, the better the questions are going to get. So Gore-Tex is another type of suture that is increasingly being used. It's not very commonly used because it's not made for ophthalmic use. It's more so for cardiac use. But many of my, not many, but a few of my VR colleagues have begun to use it in India as well for suturing these scleral fixated IOLs for a 4-point fixation, which gives you a better stability. So this is something that you can remember. You can read up upon it about Gore-Tex sutures. No other indication as of now, unless Ruchi Madam.
Oculoplasty also, some of the oculoplasty we started to use. Just the availability of the sutures, but then excellent material.
What cases are you using it for?
Like mostly whenever we have to do any kind of periosteal fixation or those like the tissues to match the tissues. So those kind of things. Yeah.
Thank you.
Thank you, sir.
I would like to thank all our gurus who have agreed today to be here and share their knowledge on their subject. Dr. Thakur sir, Dr. Meenakshi ma'am, Dr. Chinmay ma'am, and Dr. Indu ma'am. Thank you so much for your time and efforts into putting up the session together. I would also like to thank all our panelists for their active participation and brainstorming discussions on all the topics. It was a success thanks to all of your participation. Thank you so much, everyone. And with this, we would now culminate the session of GuruSangam, General Ophthalmology session for today. Have a happy and a very successful and fulfilling Sunday, everyone.
Thank you.
Thank you, everyone.
Yeah, I'd also like to thank SH and Roleka, apart from you, for having this foreign body in this session, a retinal foreign body. So I learned a lot. It was very refreshing to listen to so many new things today. Thank you very much.
The pleasure is all ours, sir. I think Sir has shared the name of the book. It is Eye Surgery from George Iser, 1980-1990, third edition.
Okay. Thank you.
Thank you.
Thank you, everyone.
Thank you, everybody.